Nate's idea is to really get after this neuroendocrine prostate cancer. And so I'm going to let him obviously tell you why that is, and he's going to give us a kind of an overview. And again, we usually try and have a very broad base audience for this, so it's going to be somewhat educational here in the beginning. We don't want to lose people too quickly into the ferns and the rainforest, but it is going to be a bit focused on neuroendocrine prostate cancer and quandaries in that topic. Okay, Nate, take it away.
All right, thanks, Alan. Yeah, so I was requested to give a brief intro here, so I'm going to try to keep it as short and sweet and basic as possible, like Alan said, not to get anybody lost, but get us all sort of on the same page to start with. And then I kind of want to listen to what the pathologists and the clinicians have to say about this and educate myself as well. So let's see, is it moving? There we go. All right. So just briefly, right, adeno versus neuroendocrine cancer. What are they? Carcinomas are cancers arising in epithelial cells. Adenocarcinoma, this comes straight from a pathologist, so don't blame me if you don't agree with it. We had much discussion over this one. Is a form of carcinoma derived from a glandular epithelium and or displaying morphologic, immunophenotypic, or ultrastructural features of glandular epithelial cells, right? So they have like some features of the original tissue from which they were derived, can be gland-forming histology, mucin vacuoles, etc. Neuroendocrine tumors arise from and or display features of neuroendocrine cells, which to me sounds like a circular argument, so we should decide what neuroendocrine cells are. They are specialized cells that receive neuronal input, and as a consequence really of getting those signals, they release polypeptides and other messenger molecules, otherwise known as hormones, from secretory granules into the blood, lumen, etc. One of their main characteristics is these dense secretory granules. So they really represent sort of the integration between the nervous system and the endocrine system. Unlike the epithelial cells, which are typically, lining the surface of organs, they function almost as a protective barrier. They have tight cell-cell junctions between similar cell types and perform many of the specialized functions of that tissue. Neuroendocrine cells really are rare, isolated cells scattered throughout the tissue. They have nerve-like dendritic processes. Since their first discovery, they've had a series of different names. Argentaphin cells, which is related to their propensity to take up silver. One of the initial ways they were really discovered and characterized was through electron microscopy. Endocrine paracrine cells, apud cells. There's a few others, but neuroendocrine cells is by far the most common name used sort of in the modern era. Neuroendocrine cells in the prostate specifically, again, they're rare. It's about 1% or so of the normal epithelium. They're AR negative, PSA negative, P63 negative, basal and luminal cytokeratin negative. So they're not all the cells we generally think of in the prostate, the basal and luminal cells. They're also not fibroblasts or stroma, things like that. They're synaptophysin positive, positive for chromogranin A, B, NCAM or CD56, things like that. For anybody that doesn't know, neuron-specific enolase is commonly used. That is the world's worst marker as far as I can tell, so don't use that. They're post-mitotic, meaning they're Ki67 negative, among other things. And they're thought to be, although this is a little controversial, derived from epithelial stem cells. I think most of us believe that because they are post-mitotic, they have to be coming from someplace because they do seem to increase proportionally as even during neoplasia. So their new ones are coming from someplace. They're also HOXB13 positive, although they're very, very, very low levels of HOXB13 positive. There's some recent evidence that there may be at least an initial wave that's derived from the neural crest, but that's also controversial. And what they're actually doing in the prostate is largely unknown. There's hypotheses that they regulate growth, differentiation, exocrine secretory activity, contraction, things like that, but nobody has a real good handle on what they're doing as far as I can tell. Neuroendocrine prostate cancer, in contrast, it's also extremely rare in primary prostate cancer, so de novo neuroendocrine. I'm not going to get into a lot of the details of this. I'm going to save that for Tamara, who's the expert here, and Eugene for the clinical stuff. The question is really, we know they're rare in primaries, and that doesn't seem to be changing. depending on what how you define them. But there is evidence to suggest, or at least people are proposing, that their frequency is increasing with metastasis, and I'll touch on that in just a minute. It can manifest in different ways: pure neuroendocrine, small cell, large cell, mixed, neuroendocrine-like, neuroendocrine features. In my mind, part of the problem is we have all of these different words, and I don't think most of us have a really good handle on what any of that really means. Where do they come from? Some neuroendocrine tumors seem to come from neuroendocrine cells. I don't think people believe that in the prostate, at least. The predominant theory at the moment is really that it's lineage plasticity, or transdifferentiation from a luminal AR positive cell that's transdifferentiating into this neuroendocrine phenotype under appropriate or selective pressures, therapy induced. Another theory is that they're actually derived from an uncommitted or progenitor type tumor initiating cell that has a little bit more flexibility to start with. Their genetics, they're highly enriched in mutant P53, RB loss. There's been a whole series of things. It seems like every other week we did a new paper claiming that this is the driving force behind neuroendocrine prostate cancer. PTEN loss, EZH2, DNA methyltransferases, SOX2, FOXA2, NMYC, YAP1, REST, ASCL1. I mean, the list goes on and on and on. Most of these, at least in the models that we use, don't seem to hold up. They might be necessary, but they're certainly not sufficient, because we have models with all of these and they're not neuroendocrine. ASCL1 seems to be one of the ones that holds up at least the closest in our experience. And again, so Eugene's going to give a much better picture of sort of the clinical overview or the clinical landscape, but just to give you an intro of why I started becoming interested in this, most prostate cancer is an adenocarcinoma, and it maintains its dependence on really the androgen signaling pathway throughout its progression. Advanced metastatic disease is uncurable, and androgen-targeted therapy really is not only the first line, but the second line, third line, and fourth line therapy, as far as I can tell, throughout the progression. So once you develop biochemical recurrence, which means your PSA is coming back after local therapy, either surgery or radiation, you know, they start hitting you with anti-androgens, and they keep going through more and more potent androgen axis targeted therapies. And the theory is, well, inevitably patients develop castration resistance to all of these agents, and this is lethal if the patient, you know, doesn't die of something else first. And so one of the proposed mechanisms for how these patients actually become resistant to these AR axis targeted therapies is through the development of sort of a neuroendocrine phenotype, which is AR negative. Now, it's certainly, even by the proponents of this theory, it's by far not the most prevalent mechanism for castration resistance, but there is a theory that as patients live longer, we get more and more potent anti-androgens or agents targeting the AR axis, that we're driving patients essentially into a neuroendocrine phenotype. And so the theory, right, is that this is becoming more prevalent and is only going to continue to increase moving forward. Some of the data or evidence to really support this hypothesis comes out of a bunch of groups, but I'm just going to highlight two papers really quickly. This study by Eric Small, group out at UCSF, in addition to a bunch of colleagues from various institutions, showed that in 202 consecutive patients that underwent biopsy, small cell neuroendocrine prostate cancer was detected in about 17% of them based on histology. They did, you know, some RNA sequencing too, but the pathological diagnosis of small cell was based on histology. And so what they claimed or decided, by the 75% of those patients were pure small cell, and the remainder, the other quarter, was mixed histology, which Tamara is going to touch on a bit more during her section. And so because all of these patients, or most of these patients, had previously progressed on abiraterone or enzalutamide, you know, these next generation, more potent AR axis targeted therapies, they termed this state treatment emergent small cell neuroendocrine prostate cancer, suggesting, right, that the therapies we're giving these patients are actually driving them into this aggressive phenotype. Now, this is certainly—
Hey, Nate. Hey, Nate,
Yeah.
This is Ken. There's several people in the chat already asking how to ask questions and whether
Okay.
we should be breaking in to chime in. Alan, how do you want to do that, man?
Exactly. Chime in anytime.
Yeah, so
you can type in the chat. We're watching the chat also, and we can break in with add a question if somebody doesn't want to actually ask it via audio. But feel free, anybody, anytime, to chime in, interrupt the speaker, slap them around, challenge them. Definitely.
Yeah. If anybody knew about our lab meetings, if you didn't interrupt me several times, I'd feel uncomfortable. So don't feel shy.
Yeah, and I'll just point out that, and I hope Tamara is going to talk about this, but I mean, you've brought up, and one of the reasons we've had this meeting to begin with is the discrepancy between this data on the West Coast versus the data in Texas versus our data, where we don't see 17% pure small cell, and that's part of why you brought this up to begin with. So I just point that out to the 40 other people on the call. Not everybody knows that backstory of why you wanted to start talking about this.
Yeah, so I was going to touch on that actually, I think in the next slide or so. But yeah, then we'll get to Tamara, who can actually hopefully tell us what we're actually talking about. So again, so one of the few studies I've seen that's actually done a reasonable job of really trying to compare, is this phenotype increasing pre and post, enzalutamide, abiraterone, so these next generation sort of second generation AR targeted therapies, was a paper a few years ago from Pete Nelson's group. And depending on how you quantify it, either based on the patient, did they have any tumor with this histology, or the individual tumors, you would say either, neuroendocrines may be doubling or staying the same if you look at the number of tumors. What's really increasing in their cohort anyway is this so-called double negative phenotype, which is more than quadrupling. And so double negative is defined as both AR negative and neuroendocrine negative. So in their hands, this is really the phenotype that's increasing. That's really not the subject of today's sort of discussion. I just wanted to bring it up to say that not everyone believes that all patients are going to become neuroendocrine phenotype in the next 10 years, and we need to totally do something different. But there is a substantial cohort of people that do say that.
Hey, you've already alluded to it partly, and I know we're going to get into it more deeply, but how you define these things as neuroendocrine prostate cancer. Obviously, there's a lot of different markers, and there's histology, et cetera. And so in this particular paper, I see they stained for two markers, synaptophysin and chromogranin. Was that the definition of neuroendocrine in this paper, or did they evaluate other aspects of potential neuroendocrine phenotype?
No, they also have a panel of an RNA-seq panel of at least 10 genes for a neuroendocrine AR that they use to stratify.
So let me just clarify to the non-pathologists something that's unique about prostate cancer relative to other tumors. You can take, and this has been done a long time ago in many studies, you can take usual prostate cancers, Gleason 6, Gleason 7s, they don't just run-of-the-mill prostate cancers. And if you stain them with synaptophysin or chromogranin, a large percentage of them will have neuroendocrine cells. And many studies have shown that has no prognostic significance. So just the nature of having some neuroendocrine staining in a prostate cancer does not make it a neuroendocrine tumor or neuroendocrine, carcinoma. And that's, again, unique. You don't see that in urothelial cancer, for example, in the GU tract. So the definition of something being small cell carcinoma is based not on the clinical, not based on doing a stain, but based on the morphology, which can be complemented by doing certain stains, especially in difficult cases, to separate them out from usual prostate cancer. The other thing that's unique about prostate cancer versus many other tumors is that there are hybrid lesions that are kind of transdifferentiating from high-grade usual to small cell that kind of have features of both morphologically and immunohistochemically, which again are difficult to classify.
Yeah, definitely. I think Tamara is going to get much deeper into the histology aspects of this, so I'm not going to pretend I know what I'm talking about on that front. So the one thing I would say is one of the questions I have is de novo neuroendocrine, whether it's pure or mixed in a primary setting, the same as what these other groups are discussing in the metastatic setting? Is it really the same thing, or is it a completely different beast? And I'll just put that out there for discussion as we move through the rest of the talks. So, yeah. And then so really, we've seen literally an exponential expansion in the number of papers coming out on neuroendocrine prostate cancer, really starting 20 plus years ago, but really accelerating over the past, 10 or so. I mean, these are very high impact journals, very high impact papers from, many of the leading groups all over the world, your Nature, your Science, your Cell, if that means anything to you. So this is gaining a lot of traction and a lot of interest. And my question is, how I got interested in this initially, and sort of the genesis for this talk was, we're really a preclinical drug development group. I mean, that's what we do. We're, translational scientists to the best that we can be while being at the bench. But we have strategies really targeting neuroendocrine prostate cancer, neuroendocrine phenotypes, and some of these are really quite potent. I've seen 1.2 cc tumors shrink to less than 0.2 cc's in the period of 21 days. Like, I've never seen that with any other therapy. So we're quite excited about them. We have therapies targeting double negative disease. We have therapies targeting, your canonical AR positive adenos. But what I really want to know is, do we even have these patient populations at Hopkins? If we had a strategy or a therapy that, we could move into the clinic, do we even have the possibility of testing them here? Because drug development really isn't a one size fits all sort of approach anymore. I mean, we're really looking at tailoring our approaches to specific subsets of patients that are going to be most responsive to those therapies, and doing something else for a different subset because it's not appropriate. So I really asked the group, if you believe the literature, and you believe sort of what everybody's been talking about, at least recently, if not the last 10, 20 years, if this is true, why don't we seem to have these patients at Hopkins? When I asked some of the clinicians in our GU group here, they all told me, well, we don't see those guys. They just don't exist at Hopkins. And so, this is just a series of questions that I came up with, or possibilities. Is it a myth? It's, they just don't exist. We're treating patients differently here than other centers. So are we altering the natural history of the disease? And there's some evidence that might be true that I think Eugene's going to talk about. Is it just different definitions? We have like 10 different groups with 10 different ideas of what makes neuroendocrine and what doesn't, and none of us are really on the same page. So we're just talking across purposes. We're not biopsying enough for finding, or the right patients to find it. So we're just not looking hard enough because we don't really biopsy metastatic lesions frequently here. Is this simply a cancer cell biology question that basic scientists are getting excited about, that has really minimal clinical significance or relevance, that's really been blown out of proportion? Is the world focusing on the wrong population, or we? I guess is another way to put that. But if it's true, and even if it's a minor population, let's say, the estimates range from 10 to 20% or 0% if you're at Hopkins, can we make a significant impact in this subset of patients? And if we can, could we even do trials like that here? Or all the neuroendocrine patients, because they're rare, they're all going to one or two places that really specialize in this, and we don't have, just nobody comes here because that's not what we do. Or any one of a million other sort of possibilities for why we don't seem to see these kinds of patients here. And so again, I asked the group, why is there discrepancy between, sort of what other groups are claiming they see and believe is happening, the trajectory going forward into the future, and what our experience here at Hopkins seems to be clinically. And with that, I'm going to turn it over to Tamara, let her tell us what we're actually talking about, define the beast, so to speak. And thank you for listening to me.
Thanks, Nate. That was awesome. Vasily, a quick question. Do we know what the actual numbers are at Hopkins if we made, some sort of uniform definition of what we're going to call neuroendocrine based on biopsy metastases and the number that we have at Hopkins, and really do a sort of central review and figure out what that fraction is? Has that happened already, or?
Informally, formally, I don't believe so. Informally, I think Eugene's going to touch on that, or maybe it would be more appropriate for one of the clinical folks to really speak to that.
Yeah, because maybe our number is going to be in this range, or not zero anyway.
What I was told when I inquired about it was like, we don't see those guys.
All right, but that's anecdotal. I'm just saying, can we, if we had applied sort of uniform criteria to evaluate it formally on all patients that we had biopsied, I'd be curious to know what the number actually ends up being. If it's, very low, like fractions of percents, or, low digits, low single digits, that's different than, let's say 10%. And then second, I think the other thing that I've heard from our medical oncology colleagues that are here versus others, and it makes sense the way we think about it. Many of our medical oncology colleagues, I think, don't treat with ADT as early as in some other places where biochemical recurrence often already prompts androgen deprivation therapy. Here, I think there's often a tendency to wait until there's overt metastasis, which again makes sense to me. But could that be a factor?
Yeah, that's the explanation I keep, or a hypothesis that keeps getting put, that I think is extremely provocative and interesting, and I think should be discussed.
Well, I mean, I think it gets to, it really depends on how we define what you want to define, because it could be 100% of our patients, or it could be none, depending on the stringency. I mean, if you look at P53RB dual mutations in those genes, the numbers are very, very small. If you expand it to other genes, it's a bigger number. But I mean, again, it really depends on what it is that we're trying to, and I think that's part of the problem is some centers have set their it at these things and they get 17%, and we've set our it at more stringent and we get 2%. And we may, I don't know, I worry a little bit about there's some branding going on. We're almost creating a disease to support some funding maybe, but that's why I think it's important to kind of, I don't know. It seems like, we had this meeting at the NIH before Andrew Hershevitz passed away that was on lineage plasticity, another term that we use. And it was interesting because, again, there's all these different groups and there was really no good agreement on what it is. But, Eric Small kind of presented and kind of, I guess he defined some things about what it isn't. But it was clear that there were really no obvious parameters other than taking a piece of the tumor out of the person and doing actual genetic analysis that would allow you to come up with some kind of, I mean, if you looked at like clinical presentation or PSA or chroma, there was nothing that popped visceral, but none of those things. It was really, a biopsy, looking at gene expression and defining, okay, we're going to call neuroendocrine cancer this, and here's the genes that we expect to see. That was really the hardest, but that's hard to, short of taking a piece of tumor out of everybody, it's kind of hard to make that call.
Sam, can I add something? It depends what you biopsy, and at Hopkins we biopsy a lot of patients going on clinical trials, and our theme has been AR focus and BAT focus. And so we just did a trial of 45 patients where we biopsied every one of them at baseline, and then we biopsied 38 of them after 12 weeks. And Angelo DiMarzo told us that none of them, 0, had neuroendocrine. And that might sound surprising, but on the other hand, we are selecting patients based on, they have to be PSA producers, their PSA has to be rising as an eligibility criteria. It can't have visceral mets, right? Because we worry about giving bipolar therapy to visceral patients. And so it's not that we're not seeing these patients. We all have patients like this. Mario at this moment has 5. I have 3 or 4. Sam has a couple, but we're not biopsying these guys, and we're often not offering them trials because we don't have trials for the AR indifferent. So we all see patients with massive progression of disease with PSA of 0.2, and we don't necessarily get a biopsy to confirm the histology. We just give them platinum, and that might be the wrong thing to do. Maybe we should be biopsying them, finding what their biomarker is, and then referring them to Nate for a targeted therapy. So
would you say that's 17% of our patients or 1.7%?
Well, I would say it's 5 to 10%.
So can I just comment on the 17%? So the 17% comes from the West Coast Dream Team. So they had this prospective trial in which patients who had evidence of disease progression were then biopsied. Not everybody got biopsied. A minority of these patients actually got biopsied. They obtained, I don't know, 2/3 or 3/4 of those patients that have tumor that could be studied, and there were different locations. So that's 17%. This is 17% of the biopsies obtained. That doesn't mean there is 17% of the patient population who was in that multi-institutional trial. I think the 17%, I was very surprised because I thought it was so much higher than what one would expect. When I looked into it, I got really confused because I didn't see it a uniformly defined subset of patients who had the same findings. So in the past, we used to biopsy them here. Somebody would have evidence of disease progression, a short duration of response to androgen deprivation. We use a 12-month sort of cutoff time, and then progressed rapidly. So there was a selection bias there. But if somebody has visceral metastasis or bulky metastasis, I would always biopsy. And I tell you, I almost never found a true small cell. I've been here, we probably have less than 10 patients who presented with small cell in patients who progressed on androgen deprivation treatment. And we had probably an equal number of patients, which is very unusual, and those who presented de novo. I wasn't so sure that they were the same. Morphologically, I see a lot more small cells in those patients who present de novo. And I very seldom see small cell. I used to ask Jonathan, is this a small cell? Does it have chromogranin? And I got the answer that we all just heard a few minutes ago about it. I think it's a lot less frequent. That's just, I wanted to comment here.
So how do you, how can we clarify Emmanuel's 5 to 10% versus Mario's 0.1%? I mean, you're both seeing the same sort of population of patients. Emmanuel, why did you come up with such a higher number than Mario did?
Let me say, I don't systematically biopsy. I think we're at different times. Today, drug development frequently requires a biopsy. So I think the number of patients today that got biopsied is a lot higher than I used to do. I used to biopsy a number of years ago, those who can presented with these rapidly progressing tumors, visceral metastasis. So I selected it that way. And that was something like, what, 6% of the patients or so had metastasis in the liver. The pulmonary metastases, I thought it were different. I didn't biopsy those. So it was essentially hepatic metastasis. And that was very uncommon. So it's difficult to compare. I wouldn't say 0.1%, but it's very low. It's probably no more than 1%. I don't know why. I mean,
the other part of just for me to understand also about it is just, obviously a fraction has two parts, the numerator and the denominator. And we talked a little bit about the numerator not having uniform definitions of exactly what small cell and how we identify all that kind of stuff, and that can cause some fluctuation. But also the denominator of who we sample and can incorporate into it. So if we had, for instance, only patients that had de novo mets or ADT alone, one argument might be that those individuals may not have yet had enough androgen receptor blockade to drive them into this phenotype, and you need to have multiple, rounds of second generation anti-androgens or AR-directed therapies to ultimately emerge. And so if the denominator included mostly people that had sequential or multiple AR-directed therapies, maybe there'll be a higher rate because whatever the numerator is, whatever it is, and then the denominator becomes smaller and enriched for the people that might have an event like that. That could be one possibility as well.
Well, I think I also, when we started talking about having this meeting, I sent a case out to you folks, and I'm like with Mario, I've only seen a few. My clinic isn't as big as Emmanuel's and Mario's, but and just as an example, I had a guy recently with no PSA. He's had 3 parts of his body removed for metastases. All 3 have been evaluated here, and all 3 have been classified as adenocarcinoma. So he looks clinically like neuroendocrine prostate cancer, but pathologically, and he has mutations that would put him in the neuroendocrine bin, P53, RB, but pathologically, he's adenocarcinoma. So the spectrum is just sort of all over the place, and it's really makes it difficult to even understand what is the numbers.
Yeah, I agree with that too, because there's additional classifications coming through that make how we were going to evaluate this more confusing, like the idea of double negative, or things that are AR negative and neuroendocrine negative morphologically, but another resistance mechanism that we don't quite yet understand. That's still adenocarcinoma morphologically. That's also crept in. But I wonder, Sam, if you had, like, let's say 50 people like that, would the rate that are truly neuroendocrine, meaning AR negative, have those markers still morphologically looking like neuroendocrine small cell, making those markers, maybe that denominator with those 50 would be like 50%. I don't know. I'm just,
I agree.
Yeah.
I agree. I think it's, but yeah, it makes it hard here, though, to just kind of, like for what Nate's doing, to try to apply for support and for trials to say we're going to have something in neuroendocrine, and then we say we don't have any patients. So,
well, one thing that I think we can think about is, because part of this is that we need to get tissues from everybody in order to even start enriching for populations that might have that. Maybe one thing we can think about is, with the existing data out there with various molecular markers like DNA methylation, mutations, things like that, see if we can make some liquid biopsy assays. I think DNA methylation is probably the most tractable along those lines, because it's so widespread in the few studies that have looked at it, that there's like genome-wide significant shifts, and they're so compelling that I've actually started, really looking at that to think about what could be driving that, because it's just a huge shift in the DNA methylation landscape in those types of morphologies compared to adenocarcinoma. It might be, doable to take cell-free circulating DNA from those individuals and see if we can find signatures that go along with the tissues that have been biopsied in other studies. That might, help us enrich. I don't think it's going to be diagnostic, because we still need to understand how it correlates with the morphology to know it's a valid biomarker. But maybe if we just sort of get liquid biopsy specimens from folks that some fraction of which are undergoing biopsy as well, we can start seeing if we can get a biomarker that can help us figure out who might have these criteria.
I mean, I'd like to know something a little straightforward, simple. From Tamara, what is morphologically a neuroendocrine tumor?
It's a great intro. Let's have Tamara start her slide. Perfect intro.
So I'm definitely not going to have all the answers here.
Oh, come on. We're not going to invite you back.
But I will give you my sort of biased account of this, and then Jonathan can jump in with his thoughts. So my strong feeling is that the definition is very difficult to nail down, as we've sort of alluded to already. And all these studies are using kind of different benchmarks, and even among pathologists, perhaps many cannot agree. So I think we need to sort of think about this as like a multimodal analysis. I don't think you can look at just morphology or just molecular or just AR signaling. You have to kind of look at this whole complex. And when I think about small neuroendocrine prostate cancer, I sort of think about 4 bins of, characteristics that you need to sort of add up to neuroendocrine. So the first, which Jonathan mentioned, is morphology, right? Optimally, we would like to have the, a tumor that clearly looks like small cell carcinoma. And I'm going to show you some examples on the next slides. But, the features there are, very high nuclear to cytoplasmic ratio with, without prominent nucleoli, nuclear molding, et cetera. And I'll show you some of those features. But I think that becomes, that may work in the primary context, and it works pretty well in the primary context. But I think once you start applying AR-directed therapy, you start to get these sort of hybrid cases that everyone mentioned that become very difficult morphologically to bin into clear categories. So then there's sort of 3 other main areas, which we've touched on a little bit, but one is, the concept of neuroendocrine markers, chromogranin, synaptophysin. There's now a whole laundry list of various markers we can apply. And
I would just break in and say there are some cases of classic small cell that actually don't express neuroendocrine markers.
Yeah,
meaning
I'm going to show
such rare neuroendocrine granules, you just don't see it, right?
Yeah, I'm going to show some examples of that too. Exactly.
So why is large cell excluded? Do we just not see that in prostate?
No, you do, rarely.
Very rarely, yeah.
Okay.
But
For
the
the
other thing I
purposes-
would also add, and you might get into this, to me, one of the things I use definitionally is they don't express, like NKX, PSA, prostene, except rarely. So if you see
Right.
something that you're questioning small cell and it's diffuse staining for prostate markers, that's not small cell.
Right. So that's really the last category here, which is AR. So the first is sort of increased expression of neuroendocrine markers, and these three categories are going to hold up on gene, signatures as well. And you can really bin all the genes you see go up and down in neuroendocrine versus adeno into these main three bins. So you have kind of neuroendocrine markers, you have cell cycle markers, and I think that obviously the key driving force there is loss of RB and P53. And my strong bias, which I've had for the last decade or so, is that these are really the key drivers, or maybe these last two categories are sort of the key drivers that are driving therapy effects, and that's what we should be focusing on. I think the neuroendocrine markers are kind of just going along for the ride, and they're correlates of this increased cell cycle activity and this decreased AR signaling.
And Tamara, is maybe you can comment on this, but it's my understanding that for neuroendocrine for small cell cancers elsewhere, typically this is the marker is P53 and RB loss. Is that how prevalent is that? I mean, that kind of makes a strong case, right? That there's something about that.
Right. So in lung, it's almost a sine qua non. It's like, pathognomonic. Essentially, you don't have cases of small cell lung carcinoma that don't have RB and or P53 loss, and almost all of them have both. And I'll show you that data in a minute.
You need to share your screen so we can see your slides.
Oh, I am sharing, huh?
I'm seeing it. Is anybody else not seeing it?
I'm not seeing it.
I see the slides.
I see it.
Yeah. Open your eyes, Nate.
Well, I screwed up something then, sorry.
Okay. And then the last category is this category of AR signaling markers. So that's sort of what Jonathan was alluding to. Looking at PSA or NKX by pathology can be helpful, because I think they give us some limited insight into AR signaling dynamics. And then, clearly there are these hybrid cases. And I think if you take one thing home from this talk, is I think we're not going to arrive at a definition until we, sort of test some of these markers in clinical trials to just see what is most important for what therapies. I just think it's very difficult without trials. Of course, it's a little circular because you can't do a trial without a definition, but I think we have to maybe start with some of these molecular features and do trials in these, settings and see if we really need these other, for instance, neuroendocrine markers in that setting.
Tamara, there's a question in the chat.
Oh yeah.
Is HDR deficiency BRCA1, BRCA2, etc.
Enriched? Yeah, let me see. Sorry, I can't see the chat when I have my screen like this. Let me see if I can pull up the chat. It is not, as far as I know. There may be a slight enrichment actually for mismatch repair defects. That's something we're just preparing a manuscript on right now. But not BRCA1, BRCA2, or HRD, as far as I know. Okay. Let's see if I can now.
Tamara, would you say there's anything neuro looking about any of these? I mean, I just think the term is garbage. It just seems like they're not really endocrine. They're not really neuro. I don't know why we even have the term. It seems like something from the 19th century that we're dealing with. So
because they had neuroendocrine granules. The definition histologically was that they had these characteristic, organelles.
but we don't really look for those, do we?
Well, I guess when we're looking at these neuroendocrine markers, we're looking indirectly at some of these. But yeah, I think it's a carryover from the lung classification, right? Essentially, or from other organ systems. But you're right, they don't look neuronal specifically. So this just gives you an idea of the spectrum, and I think the difficulty in looking pathologically at these cases. So on the far right, you have kind of a classic small cell. You have this nuclear molding where it looks like these are all sort of tiles in a mosaic or something. They're all sort of just molded against one another. You can't see any nucleoli. You have just sheets of cells without any glandular features whatsoever. Typically, they kind of just tear through the stroma. You don't even see, in just large sheets, essentially. On the left, you have maybe a very high-grade adenocarcinoma where you see prominent nucleoli. You don't see the same nuclear molding. The chromatin has a sort of different texture compared to the small, classic small cell carcinoma. A small cell carcinoma typically has a very high proliferative and apoptotic rate, although you can sometimes see a higher rate in adenocarcinomas, particularly in the treated, setting. But then we clearly have cases that are in between where it's, becomes difficult to discern based on morphology. At least for me, sometimes you're not sure if you're looking at more glandular architecture or these, rosettes that would be more, neuroendocrine features. And so I think it becomes very difficult on morphology. And that's why there's not a lot of inter-observer agreement, particularly I think in the treated setting. So this slide is actually pretty similar to the slide I've been showing for the last, 7 or 8 years. There was a meeting put together by Mark Rubin, and Jonathan was there as well in 2006, or I guess prior to 2016, where this classification was put together that was subsequently used in the WHO classification. I sort of think of it being along a spectrum. So at one end of the spectrum, you have usual type adenocarcinoma, which typically in the untreated setting, of course, you can have post-ADT tumors that are also typical adenocarcinomas, and they may have very minimal chromogranin or synaptophysin expression. But then there's another set, typically a little bit higher grade, which is also usual type adenocarcinoma. But if you put a stain, a chromogranin or synaptophysin stain on it, and I'm going to show you an example of that in the subsequent slides, the whole thing lights up like a Christmas tree. So this is why these stains become very problematic. And you can see more of this kind of staining in adenocarcinoma when it's post androgen, androgen receptor directed therapies, but you can also see it in the untreated setting. So these are really just usual type adenocarcinomas that happen to have neuroendocrine cells in them.
Or how distinctive are those as a pathologist? If you just looked at an H&E on that, would you be able to reliably predict, yeah, if I throw the chromogranin on there, we're going to see a lot of positivity, or is it kind of hidden?
Yeah, not at all. I mean, at least not for me. They tend to be higher grade. So although you can see it occasionally in lower grade tumors, but I don't think it's easily predictable. Yeah, there's some rare subsets that have these Paneth-like cells that Jonathan and others have described, where you can identify those on morphology, but those are very, very rare subsets of neuroendocrine differentiation in usual type adenocarcinoma. And so then as you move into sort of the post-treatment setting, or at least sort of towards the right end of this spectrum, you tend to get these more mixed cases, as I mentioned. And then of course we have, just classic small cell cases, which again, I think are somehow morphologically more common in the untreated setting.
So in post-treated, are we talking primarily now about biopsies of metastases?
Yes.
As opposed to primaries?
Yeah.
Okay.
Yeah. That's usually where we.
Does it matter where, what site of metastasis it is? Does it vary how much you're more or less likely to see this? Bone mets more or less than visceral, or anything like that?
Yeah, I mean, I guess we tend to see more visceral mets biopsy just for the.
Well, that makes sense.
Yeah. Right. So I don't know. That's a hard question to answer. I haven't noticed a difference depending on site. I don't know if anyone else has.
Or what about if multiple mets have been biopsied? How heterogeneous? If you biopsy 7 metastases, do you see 2 that have it, 5 that don't, or something like that? Or?
There definitely can be some heterogeneity, and we've seen these cases often picked up on like PSMA imaging, where some mets will continue to light up on PSMA imaging, some will be totally dark, and you can definitely get one that's an adenocarcinoma, one that looks more neuroendocrine. Obviously in the autopsy setting, which is the most common setting where we look at multiple mets, there's not as much heterogeneity at that point typically. So, pathologists have typically used these markers that we mentioned to try to, bolster our diagnostic capabilities just based on H&E. And these are a number of studies, actually largely done by Jonathan's group, also looking at, the percent of morphologically identified small cell carcinomas, and these are probably skewed towards primary or tumors arising in the untreated setting, just by virtue of what we tend to see on our consultation service. But looking at neuroendocrine marker expression, and you can see that the vast majority express, one or more of these markers. But for any given marker, there are clearly cases that are negative, and I'll show you some examples of that. If you look at sort of the other, one of the other axes of markers that I talked about, which is either prostate specific, or I think of them sort of AR axis markers, about 20% of cases, or up to 20%, can express one or more of these cases. So the majority are negative for these markers. So typically, if you see them as negative, that's helpful, but they can be positive in some cases. And even AR can be positive. In a minority of cases, ERG can be expressed. We know these small cell carcinomas have ERG rearrangements at roughly the same rate as adenocarcinomas, sort of supporting this idea that they transdifferentiated from adenocarcinomas.
Tamara,
Yeah.
When you say they express these AR markers, are you saying they're mixed independent lesions, or the same cell that's expressing a neuroendocrine marker is expressing an AR marker, this quote unquote amphicrine phenotype?
Right. That's a good question.
I would say if you take a classic small cell carcinoma, only rare small cell carcinoma cells will express prostate markers.
These would be in the minority of the cells. And when we've looked, of course, most studies like this are single marker studies, but we've done some dual immunofluorescence studies, and AR is way down in the neuroendocrine marker expressing cells, even among usual adenocarcinomas that have some number of neuroendocrine tumors. So there probably are somewhat mutually exclusive, to get to your point, Nate. And here's, you could see some examples of, I'm going to show you a couple examples where you have an adenocarcinoma directly admixed with a neuroendocrine or small cell carcinoma, and you can see, clearly distinguish the two components with some markers, for instance, here NKX 3.1. But there are some neuroendocrine, some small cell carcinomas that will have some NKX 3.1 positive cells. We've definitely seen that. So again, as we mentioned before, there definitely are cases that are classic small cell carcinoma on morphology, dead negative for AR, but no chromogranin whatsoever. So you can't rely on any single one of these markers. And again, here's an example of a classic adenocarcinoma. Looks like an adenocarcinoma NOS. I don't think there's anything about this that would make you suspect that it has neuroendocrine differentiation, but it completely lights up with chromogranin, with a few cells admixed that are negative, but the majority of the cells are positive. And again, these don't have a particularly poor outcome. When you control for grade, they do tend to be higher grade, but if you control for grade, they seem to have about the same outcome as all usual type adenocarcinomas that don't have neuroendocrine marker expression. So this is just sort of getting at this, that these RB and P53 are really the key drivers. I think they're driving a lot of the biology that we're seeing, and that if we had to pick two markers, these are the two markers that we might want to pick to start to refine our definitions of neuroendocrine prostate cancer. You could see in the lung setting, right, almost all of the lung tumors have both alterations. All lung small cell carcinomas have both alterations. P10 is much less common in the lung, so obviously fewer here. If you looked at prostate, you do see a lot more P10 loss. I'm not really convinced P10 loss by itself is doing much. I think it just happens to be common in adenocarcinomas, and so it is very common in high-grade adenocarcinomas, so it turns out to be common in prostatic small cell carcinomas. And if you knock out P53 and RB in the mouse, and this is actually way before the Sawyers and Goodrich, more recent papers, you can get a tumor that looks, very neuroendocrine morphologically, does still have some AR, but clearly a lot of synaptophysin expression. So just thinking a little bit, I just want to focus a little bit on RB because I do think this is a key marker, and just point out that RB, deep deletions in RB are extremely rare in the primary setting. These are probably like very generous estimates of the percent of primaries you can find with RB loss. And this is using a number of different methods, IHC or sequencing, and of course there's some variability depending on what methodology you use. But I think it's in the single digits percentage-wise in terms of the number of primaries that have RB loss. If you start looking at CRPC, the numbers go up pretty dramatically. So there's something about hormonal therapy, I think that selects then for RB loss. It almost seems like RB loss is selected against in the primary setting for some reason. These tumors have no problem deleting PTEN, for example, but they frequently have hemizygous loss of RB. So they take out one copy with, at some frequency, probably 30% or more. But they rarely, if ever, take out the second copy. But then once you apply hormonal therapy, or at least you look at castration-resistant disease, you get much higher percentages of, again, some variability depending on the West Coast versus the East Coast cohort, or, autopsy setting versus, metastatic biopsies. But small cells in the prostate, at least by IHC, which we think is the most sensitive way to measure RB loss, and I'll show you some more data for that, almost all invariably have RB loss. And so it's clearly enriched in small cell carcinomas. And we'll see that in the LUCAP xenograph series as well. And here's just an image of RB immunohistochemistry, again, in this sort of mixed case where you have adenocarcinoma with some glands on one side, and then sort of colliding with this probably transdifferentiated component of small cell that clearly has RB loss. So just to touch on a few other markers that I think are useful, we can actually measure RB loss not just by immunohistochemistry or sequencing, but by some very simple markers which are available in every pathology lab in the US if you just want to think about doing trials. And these are P16, which is CDKN2A, and cyclin D1. And so this goes back to what has been known for a long time, that RB is itself actually driving cyclin D1 expression and suppressing CDKN2A or P16 expression, such that when you lose RB, you suppress cyclin D1 and you drive P16 expression. And this is used in pathology labs actually routinely to diagnose HPV-related tumors, because HPV itself inactivates RB. So you drive P16 expression at very high levels and you suppress cyclin D1. And we can actually use this to screen squamous cell carcinomas, for instance, for HPV infection. And we could see the same thing very clearly in the PDX series, so that if we look, this is the LUCAP PDX series, the cases with RB copy number of 0 are in red, and you can see they have a very high ratio of P16 to cyclin D1 at the gene expression level. They're also very high on various RB loss gene expression scores. And you could see that actually 4 out of 5 of the LUCAPs that have RB loss are neuroendocrine cancers. The neuroendocrine cancers are indicated by squares here. And then the majority of adenocarcinomas, with one exception here, and there are a few more in their newer lines, do not have RB loss and have a low ratio of P16 to cyclin D1, low RB loss score. We could see this across a number of different xenographed systems.
Mara,
yeah.
So BRCA2 is near RB, right? And
yeah.
So how often do you see any co-deletion for RB and BRCA2? And would that help in terms of guiding therapies or something?
Yeah, that's a good question. I don't know. I mean, Phil Kantoff has that story. Maybe Vasan can chime in, because I recall Vasan once telling me that frequently, like, the first hit to RB is a larger hit and you might take out neighboring BRCA2. But the second hit tends to be very focal, and we've definitely seen that often, just several exons, for example. And you don't, I think, tend to hit the second copy. But I don't know if Vasan can weigh in. I recall him once mentioning that to me.
Well, yeah, I mean, that's totally anecdotal, because we have an event like that in JW, one of the cases that we've done a lot of deep analysis on, and then anecdotally we've seen in some other cases where I don't know about which is the first and which is the second, we couldn't tell that, but it does look like one deletion would be like spanning a significant region, with part of it hitting part of RB, let's say, and then the other deletion was like a smaller one that hit a couple of exons or something. So I don't know which one came first, but there are events like that. And that's actually common. I know Bill Isaacs has seen phenomena like that for instance, for PTEN, where there's often very different sized deletions that take out the function of PTEN, some of them just spanning a couple of exons and often not detectable by older methods like array-CGH and things like that. And then some of them taking out large swaths of the chromosomal arm. So
yeah. Certainly, I think that the initial RB deletions in the hemizygous state in primaries do tend to be large and take out BRCA.
But I think it is still somewhat of an open question. I think part of the complication is just how squishy the definition of this is. But I would love to know whether there's an overrepresentation of developing neuroendocrine, disease or whatever in people that have BRCA mutations.
Yeah. Yeah, I don't think there's much. I may certainly be wrong, but I don't think there's an obvious overrepresentation with patients with BRCA2, certainly germline, and then even somatic hits. But what the denominator, or what the numerator versus the denominator is, I don't know.
So there was one abstract from Elena Castro and David Olmos from Spain, where they had about 100 germline BRCA2 patients that they had tissue from, and they found, of course, that they found somatic LOH of the other allele in BRCA2, and in about a third of the ones where they found LOH, they also found at least hemizygous RB1 deletion because it's on the same segment of the chromosome. So if that is true, and they didn't have outcomes in their study, so if that is true, there could be an enrichment, at least in the BRCA2 germline carriers, because BRCA2 locus and RB1 locus are adjacent to each other, of co-deletions when you lose that second allele at the somatic level.
It is interesting that these RB tumors have very high proliferative rates, and yet you're showing an increase in expression of a cell cycle inhibitor and a decrease in expression of a cell cycle promoter.
Yeah. So, well, these don't work very well if RB's gone. But yeah. This is a feedback, some kind of feedback pathway. I don't think the mechanism is totally well understood, but some sort of feedback from RB2F to cyclin D1 and P16 transcription. And clearly, as I just bring these up because this is something where, if you wanted to think about a trial, it could easily be done just because these markers are ubiquitous. We use cyclin D1 to diagnose mantle cell lymphomas and P16, as I mentioned, in HPV-related tumors. And you could see again in this hybrid case, this beautiful discordance in the cyclin D1 status and in the P16 status.
It's wild.
Yeah, and just to emphasize Tamara's point about in the history of RB loss, I think the vast majority, certainly the earlier reports were single loss events, and it's so important not to lump those together with hemizygous versus basically a null, and obviously that's the reason why staining is so great, because you can you see it's there or not. Whereas almost all, and Tamara showed this beautifully, almost all the ones with loss of one copy, they still make RB fine. And I think that's, so I think anytime you're talking about RB loss, you really have to stipulate whether you're talking about hemizygous or two copy loss.
Yeah. Just another case, this patient actually had heterogeneity within a single core biopsy we got, and clearly for AR and for cyclin D1, and actually subsequently developed a small cell liver metastasis. So just I have I think like 3 slides left, but I just want to dwell for a moment on this work we've been doing with Pete Nelson on the LuCap xenograph series, because it's kind of striking. And here we're doing kind of a comparison of multiple methods for measuring RB, so whether the RB gene is intact, whether the RB protein is intact, and then various gene expression signatures for RB loss. So on the left-hand column, you have the name of the xenograph series, or each of the xenographs, And I've highlighted in green those that are considered neuroendocrine. So they're neuroendocrine marker positive and they're AR negative. The lighter green ones are neuroendocrine marker negative, but also AR negative. So we have all the AR negative xenografts, I think, highlighted here. And then here's the RB and cyclin D1 expression results. And in blue, I've highlighted the cases where there's loss of both RB1 and then in the column next to it, cyclin D1. So you can see they're mostly concordant, but with some exceptions, which are kind of interesting to think about. And then we have two different sequencing attempts on these xenografts. One was done by Pete Nelson's lab. This is in this column here. This is whole exome sequencing where they made a copy number call for RB. And then they sent the xenografts also to Colin Pritchard's lab where he ran his CLIA-BROCA targeted sequencing assay and also made a copy number call of RB. And I just want to point out that sequencing is not always the answer because there are clearly some discordant cases. So it's not, they're mostly concordant, but there are definitely some cases where there are discordances. And then on the far right, we have the gene expression. I think this column is actually RB transcript itself. So the cases highlighted in blue have very low levels of RB transcript, typically concordant with the genomic status, as we would hope. And then two gene expression signatures for RB loss. So one was, I think, derived from some cell lines that Pete Nelson made himself, and then some from Felix Fang's recently published RB loss signature with higher RB loss scores in red here. So you can see there's mostly concordance across the methods, but there are definitely some discordances, which are interesting to think about. To me, the most striking thing here, though, is at least at the xenograph level, the vast majority of the xenografts that have RB loss, with some rare exceptions, are neuroendocrine phenotype and or AR negative. So there's a definite enormous enrichment, at least in these xenografts. And of course, that may be confounded by, which xenografts took and various other properties. But there's some rare exceptions, like 86.2 is an adenocarcinoma that clearly has RB loss. But there are very few like that. So there's a very strong overlap between RB and neuroendocrine.
So Tamara, if you back up that one, could you comment on it looks like the fact that none of the CR, which I assume means castrate resistant variants of the same number, none of those seems to be neuroendocrine, right? Is that correct?
Yeah, that is correct.
So if this is really a fundamental way to get around castration therapy and anti-androgen therapies, it seems like you'd expect to see a couple of these guys.
Yeah, that's a good point.
And is this was that castrate resistant in terms of the model? Like they had a xenograft and they,
yes,
castrate,
probably with an older,
yeah. So it's not a second prostate cancer from the same patient being grown.
Correct.
Okay.
Correct.
So it might be something about castration in a mouse versus.
Right. Exactly.
Maybe John could comment on that.
I was going to say the only model I know of that does that is there's the LTL331.
Yeah.
YZ Wang's group out of Vancouver, and it's an AR positive adeno for all intents and purposes in an intact animal, but if it serially passes through a castrate, it becomes neuroendocrine. Yeah,
it's right here. Actually, it's pretty fascinating. So the adenocarcinoma has a very high ratio of P16 to cyclin D1, but not a particularly high RB loss score. It has a single hit. I think it has one missense mutation in RB, and they weren't sure what was happening with the second allele. But then when it becomes neuroendocrine, it clearly migrates up to the very high RB loss score there, which is interesting. And we're not exactly sure what happened because it doesn't look like there's clearly a second hit to RB at that point.
But as everybody just brought up, the batting average is that's one of about 8. In other words, there's 7 other ones in that series that didn't do that.
Right.
So it's not like it can't happen, but we're asking, does it usually happen? And the answer is, if you're objective, the answer is no, it doesn't usually happen. It's some selective environment that allows that. And that also gets you back to this argument about whether it's coming from an adeno and being transdifferentiated, or it was there already and it was selected for. And so this is just really confusing to me, because we would think of it as adaptation, there would be a higher frequency than 1 in 8. And we've got a series of lines, we've done it too, and we don't see that. Where, as opposed to if it's some stochastic genetic requirement, and either you have it or you don't, if you got it, then you can grow out and you'll do that. So it's just complicated trying to think through what these low frequencies mean.
So just the last 2 slides or so. So just thinking about AR signaling markers, just a few caveats here. So, I mean, we definitely have cases where AR, it looks like a small cell for all intents and purposes, stains with neuroendocrine markers. Here's NCAM or CD56 and apophysin. Cyclin D1 is totally gone, so presumably RB is completely inactivated. But this case is clearly AR positive in both the adenocarcinoma and the small cell carcinoma areas. Clearly NKX 3.1 positive, but PSA has just completely lost in the small cell. So I don't know if that gets back to Sam's case, but Angelo and I have definitely seen a couple cases where PSA specifically is lost. So it's not always such a, I think such a great marker of the androgen signaling axis, or perhaps the loss just tells us that there's some, something is aberrant in the androgen signaling axis, but it's maybe not be completely gone. So there are definitely cases where we get that kind of discordance.
It seems like these kind of cases, it would be important to sequence the androgen receptor because maybe there's a mutate, maybe it's just an inactive androgen receptor. I don't know.
Could be. It's in the nucleus for sure, but yeah, it could be inactive, I guess. I don't know, NKX 3.1 is still expressed, but
right, that's right.
Yeah, it's confusing.
Yeah. And then just last 2 slides. So I think gene expression classifiers, this is sort of the same West Coast Stand Up to Cancer group that we talked about. This is their, where they looked at gene expression. They have RB and P53 status annotated here as well. But it really perfectly mimics the morphology, right? There is some kind of true spectrum here. And this is AR signaling, on the y-axis, and sort of a neuroendocrine prostate cancer gene expression score on the x-axis. And there are clearly cases that are hybrid and mixed and sort of in the middle. And there are cases that on pathology looked neuroendocrine to all the world, looked like small cell, but clearly cluster with the adenos. So I think, just sort of underscoring this imperfect definition and how difficult I think it will ever be to have a clear cut point, at least using these kind of concepts of AR and neuroendocrine signaling. And we did a similar study where we also developed a neuroendocrine gene expression signature, applied it to some Hopkins cases that were diagnosed on morphology, and then also to some public data sets. And again, the same sort of spectrum. Here we have kind of a neuroendocrine score and an adenocarcinoma score, essentially. And you can see that we really have a spectrum of differentiation. And to end, if you look at the different genes on, various gene expression classifiers, all of these markers we've been talking about kind of pop out, right? So the genes that are up tend to be, this is TTF1, SRRM4, right, which mediates REST splicing. Nate mentioned ASCL1, DLL3, there's trials now for this Notch ligand, SOX2, et cetera. And then if you look at the genes that are down, they tend to also be sort of these AR regulated genes, AR itself, AR targets, NKX 3.1, PSA, HOXB13, so kind of classic. So I think the pathology is only a part of the puzzle, and I think the morphology may actually be the least important part from a therapeutic standpoint. And I think neuroendocrine markers in particular are imperfect and may also not be very important, just sort of going along for the ride. I think the key biology is going to come down to RB and P53 and probably also AR signaling, and and teasing those out is going to be crucial to understanding who's going to respond to which therapies. So if I had to choose biomarkers, I would choose, biomarkers to look at AR output and RB and P53 function and sort of classify patients along those lines rather than focusing on, aberrant expression of neuroendocrine markers specifically. But clearly we need some trials. So that's all I got. questions, thoughts? I can stop sharing so Eugene can get teed up here.
Could I propose a research hypothesis? I like the idea, Tamara, of the combination of P53 and RB1. It seems, based on everything that we know, the P53 hit occurs first in most cases. And then during the transdifferentiation process, if we believe that hypothesis, at some point a second hit in RB develops. And then it's that causes the morphological and clinical transition to the aggressive variant. And one thing that has not been explored, and we've been talking about P53 for 30 years, but no one is talking about the classes of P53 mutations. I think it will be very interesting to look at the people that we have paired tissue on, in other words, adenocarcinoma and then subsequently neuroendocrine or small cell, to see whether the original mutation in P53 could be a dominant negative, also called the gain of function mutation, rather than a loss of function mutation. Because with dominant negative mutations, which are almost always point mutations, you don't need a second hit in P53 for that gene to be aberrant. It's aberrant even with the heterozygous mutation. Whereas with the loss of function mutations like frame shifts, you do need to wipe out the second allele of P53 to lose P53 function. So the dominant negative ones would seem to be more evil in the evil spectrum. And the hypothesis, at least my hypothesis, I was just brainstorming right now when you were presenting, is that it seems more statistically or stochastically probable that a neuroendocrine transdifferentiation would occur if the first hit in P53 was a dominant negative, meaning that P53 is already inactivated. You don't need a second hit in that gene. And then the RB1 is like the icing on the cake that turns it into neuroendocrine. Whereas in the loss of function P53, maybe those transform less commonly. So is it possible to look at that? Do we have data sets to look at that?
I mean, we have sequencing in the Beltran data set. You're just talking about classifying like truncation versus missense mutation, essentially. Yeah, I don't know. I haven't looked at that. And we've sequenced, a handful of cases, and most of ours have been missense in the small cell setting. We did have a couple splice site mutations, which would be more in the truncation setting. But I think you could easily look at that in the West Coast data set and in the Beltran data set to see if you have an overabundance. If you just take all comers in prostate cancer, about 2/3, I think, are missense, right? And about 1/3 are truncation.
I may be expressing my ignorance here, but my understanding from a long time ago that I thought that most P53 alterations in cancers in general were dominant negatives because it's a multimeric, it's a poisoning subunit kind of situation, which is why I thought you typically don't see complete homozygous deletions in P53 and those types of things because of the biology of P53. Is that not correct, or is that correct?
About 1/3 of cases, Alan, you have like a frame shift mutation in the first allele or a nonsense, and then you lose the second copy by a hemizygous deletion, and that's how you get to the biallelic.
In 1/3 of which cases? Prostate or cancer in general, or?
Prostate
Prostate,
cancer.
okay.
And as Tamara said, about 60% are what we call dominant negative, which are, as you pointed out, are the missense mutations.
You could get frame shifts and things also and get a partial protein product, right? That would also poison the wild type allele, presumably. So there might be a subset of those that are not. But if you hit both alleles, I agree. That seems like an indication that it's trying to completely take it out, not just. So it sounds like it's worth looking at.
I thought that most of the missense did have a second hit also, though, Manuel. Have you looked at that?
Well, none of the clinical grade sequencing platforms that we use report LOH. So we don't know. My understanding was in the leukemia literature, like the acute myeloid leukemia literature, where they have a lot of these dominant negative P53 mutations, they're almost always hemizygous.
There is another comment about the hypothesis. So if your hypothesis is true, then the HPV 16 negative infected patients, which hit the P53 and RB, should all have NECP prostate cancer.
Yeah, I guess, I mean, so there isn't known HPV infection in the prostate specifically. I guess that's a good question. I mean, you're right. It can't be so simple that it's just hitting P53 and RB in any epithelial cell will make it neuroendocrine, because clearly HPV related tumors are not all neuroendocrine, although there are some neuroendocrine variants in head and neck, I think. But yeah, and certainly in the prostate, we don't have HPV infections. I don't think we can do that experiment.
Yeah, I would also point out that in our PDXs, we have 4 from 2 independent patients that both have P53 mutations and RB loss. And they're actually a double negative, not a neuroendocrine. So, I mean, I think it's certainly part of the story, but that alone is not the whole story.
Yeah. And some of the Lou caps were like that. So, but I think there is definitely a predilection once you hit those two, you highly enrich for the potential to be neuroendocrine or double negative.
Along those lines, Tamara, how frequent is it that you have a true, what you would consider a really solid neuroendocrine? Do you ever see it without compromised P53 and RB, or is that just pretty much universal once you have neuroendocrine?
And in the cases we've looked at that are but those have been selected as from morphology and are mostly primaries. I think 90% had RB loss. So, I mean, it does happen, and some of them may have other hits in the same pathway, because sometimes we have very high RB expression suggesting, I don't know if it's hyperphosphorylated or there's some other second hit. We've seen a few cases like that, but I think in the West Coast, I mean, they definitely have some cases that don't have a hit in both of those. So nothing's 100%. I just think, I'm just arguing that we would highly enrich for those in a very easy way. We enrich for those 2 alterations. And perhaps those are all that's really moderating treatment response in this setting anyhow.
Great. So I think now's a good time to bring Eugene in.
Sounds good.
Great.
All right, let's see.
So Eugene's going to fill us in on some of the clinical aspects.
Do you guys see my pointer?
Yes.
All right, great. Man, this discussion is fascinating. So hopefully I can help out in some way. So I thought for the clinical side, kind of defining the clinical target, the treatment decision choices, and the clinical outcomes are kind of the questions that could inform the discussion on the clinical side. So let's sort of look at it that way. So we've already touched upon much of this, so I won't dwell on any of it. I think I have just a few slides and to further frame the discussion, and then we'll have kind of an open discussion even further. But as mentioned, it's a rare initial diagnosis, so less than 2%. I've seen statistics about 1 and 2, so it's about 1 to 2%. There's this treatment emergent paradigm, and it's in the setting of castration resistance. Again, we've been mentioning that. It's about 10 to 20% based on, now this goes back down all the way to the late 80s, so on autopsy series. The question there are highlighted in red is, so are we substantially underdiagnosing this in live patients in the clinical setting? And, a few things to ponder, we're kind of already talking about them, are we not biopsying the right way? And then when we do set up biopsy studies, Mario kind of mentioned it, are we skewing those biopsy studies in some selection bias way? Is there intratumoral heterogeneity? So we're biopsying, but when you do a biopsy, you may not hit. And so unlike a prostatectomy, we're just not sampling the right thing. And then, of course, it goes straight to the sampling variability. Low PSA, clinically speaking, often prompt. So if a patient has a PSA, prostate cancer, and then all of a sudden there's no PSA, one has to immediately, in the clinical setting, think that maybe they've progressed to this neuroendocrine prostate cancer transformation. And then we tend to rebiopsy, especially if it's gone to the liver, et cetera. But again, unless that's kind of, you have that clinical setup, we rarely rebiopsy, 100% of the patients or even a great majority. historically. So unless there's a trial indication, and that's very institution specific, right? And sort of depending on what the institution studies, we tend to oversample the biopsies that are in line with the hypotheses we're studying. So that's something to keep in mind. Tamara discussed a lot of the clinical sort of molecular markers and are used in pathological care of these patients. And so some things to keep in mind, TP53 will be an NGS marker. RB1 historically is an NGS with all the inherent pitfalls, but now Tamara, for example, has a great working IHC stain for RB1. So think, and then P10 can be done by IHC most of the time. So the question of how you sample, not just in terms of the tissue itself, but how we sample in terms of where our information is coming from, NGS or IHC, is another important factor to consider. And then the treatment landscape. I mean, fundamentally, we kind of know that it's an aggressive cancer. We know it's got a poor prognosis. So what's the optimal treatment? Do we have one? Well, unfortunately, there is no standard paradigm. I mean, a lot of studies try to study it, but then we're delving into the realm of the previous slide and the whole discussion thus far is, can we even diagnose it properly to stratify it, to put it into the right treatment modality on a trial? So with pure small cell, that's a little sort of a straightforward picture in terms of what we do. We tend to go to platinum-based chemotherapies, mimicking small cell in the lung. And the response rates there are still not great, unfortunately, 10 to 50%. And then I guess the vast majority of the cases that, as we're discussing today, are this non-pure variant, neuroendocrine prostate cancer. And what do we do with those? And again, there we use cabazitaxel, we use docetaxel, we use platinums plus those agents. And then of course, there's lots of clinical trials. So we touched on the co-deletion of RB1 and BRCA2, and Tamara, I believe, mentioned Kantoff. So, he argued in a clinical cancer research paper recently, a few years back, that, PARP inhibitors might be the good target for co-deleted patients. There's many ongoing clinical trials across the spectrum of many of the markers. I think Tamara had a table. So many of those markers are in clinical trial development somewhere in the preclinical or the clinical setting. So for example, and I've listed, this is just some of the ones that come sort of to mind. There's, for aggressive variant prostate cancer, there's the idea of cabazitaxel plus carboplatin and then maintenance PARP. There's chemotherapy plus pembrolizumab with the idea that maybe checkpoint inhibitor therapy plus the idea of a chemotherapy agent will benefit the aggressive cancers by the fact that maybe multiple mechanisms, including cell death, et cetera, will make a pro-inflammatory environment, and then plus checkpoint inhibitor therapy will abrogate the brakes on the immune system. Targeting.
Eugene, how does response rate compare between prostate versus lung for platinum, for small cell?
So my recollection for the lung cancer and platinum is that it's skewed, I think, to a slightly better response in lung, but I don't believe that by itself you have a much worse or much better. So overall, I'm pretty sure it's somewhat similar. I don't think it's as wide a spread, and anyone else here can chime in, but I don't remember having such a wide spread in lung cancer though, but I think on the absolute side, it's roughly similar.
I mean, I think there are two differences, and if Mario's still on, he can comment as well. One is the response rate in small cell prostate is much, much lower than small cell lung. It's probably about half. And the second is the duration of response is very short-lived. It's like 3 to 6 months, whereas in small cell lung cancer, it's 9 to 12 months. So it's worse, I think.
I agree, it's half.
Thanks, Emmanuel. Thanks, Marion.
And I'm sorry, did you mention what the efficacy is of PARP inhibitors in this setting?
No, that's a good question. So Emmanuel probably can chime in better on that, actually.
Very limited data because, we've PARP inhibitors in BRCA2 homozygous deletions, which are somatic, is very good because once you have a homozygous deletion, you can't make reversions and other BRCA-related mechanisms of resistance. Whereas the combination of RB1 loss and BRCA2 genomic loss, we've had a handful of patients But it's really too early to know, and I have not seen publications on that. I suspect that it's going to be a little bit worse.
Well, the problem is that they're all done in clinical trials, which exclude the small cells.
Oh.
Most clinical trials with new drugs exclude small cell variants. So we won't know. Hopefully now that question will be asked. You know better than I do about that. Emmanuel maybe can, but I don't know. It's a very frustrating tumor to treat. In general, you could see some responses. They're mostly partial and they don't last long.
So yeah, unfortunately, I haven't seen too much data there either. So for the sort of the other targets, everything is sort of in development, and then it comes down to the fact that some of the therapies, for example, DLL3, Rova-T as a target failed in its phase 3, but then it was also abandoned. So in prostate development, it's also banned. But there's other DLL3 trials. There's preclinical models. So there's a lot of markers being looked at, but nothing so far has really been shown to really be an effective target per se. But I would say it's pretty early in terms of where many of the therapies targeted to this neuroendocrine prostate cancer sort of subtype are, with us not even truly defining the target seems to be the biggest problem to some degree. So I mentioned here that one of the things that's hard is defining the target. And so the idea is that if you look at, the reference 3 over here that I highlight for platinum-based chemotherapy responses is the idea of how they selected the patients, and it's kind of been referred now to that as the Apparatchio criteria. But if one delves into that, as I kind of put it up over here, one realizes that the way that they defined for this trial eligibility was that they outlined basically 7 criteria, and you needed to have at least 1. So they really hedged their bets. And this talks about the problem that we don't know how to select. So if you really knew how to select something, you would say, these are the targets, everyone has to meet them. In this case, they said, we have these 7 possible targets. If you meet 1 or more, and that makes it very difficult to understand sort of what exactly you're targeting. We can look at them, right? So obviously histologic, metastasis, radiographic, bulky or not, PSA level, again, neuroendocrine markers, and we discussed the benefit or not of just looking at neuroendocrine markers, and then the duration of progression. So as you can see, this really hits clinically on almost every category of what you can imagine one can define a clinical definition of prostate cancer differently. And so it's very hard to see what the unifying theme here realistically is. And that makes it hard to potentially understand the clinical response. So it's 2021. To summarize in a way, and then I'll have a slide just on some patients, matching patients to treatment. Do we know the optimal way? No. Do we know the best treatment options? No. Do we know what the role of imaging is for trying to select these patients? No. Do we know why there's a variance in frequency by cancer center, which is actually the discussion of how this originated with Nate's excellent observations? And that's still unclear. I will say that one thing that, as I was putting this together, and I think we've already touched base, so it's apparent to a lot of us, is that we do things differently at Hopkins than many other places do. We don't routinely treat biochemical recurrence. And so that means that there is a lag time of months to years that our patients have before they routinely undergo treatment with anti-androgen therapy. In terms of what that means exactly, well, it could mean many things. But for example, again, a hypothesis that could come to mind with no data behind it necessarily, is that if you have, and this is coming out of the ideas that we're currently sort of pushing around in the oligometastatic versus widely metastatic setting. If you impact the cancer as it's sort of flexing its biological legs, so to speak, about how it's going to devote resources to which mutations, et cetera, and if you impact it earlier in its mutation course or later, you may be driving the phenotype differently. So that is something that theoretically could be in play, but that is just a observation based on how we approach treatment here. You know, we touched base on how we biopsy, how we, as a community, and this is not just Hopkins, this is just clinically speaking, do our sampling to understand this disease. There's cost, there's issues of, do we sample, even if we're talking about biopsying, most of us are clinically speaking mostly about visceral, because for bony only mets, then it comes down to, you know, other criteria of pain, accessibility, even how we study it, right? The staining for bone mets is different than visceral. And then the last issue is accessibility, but that applies to visceral organs too. So if we're sampling for biopsies, that's already by convenience in a sense, or what we can feasibly do with a patient who has bulky enough disease or in a safe enough location. So those are all considerations. So then going to, I think where this will set up an amazing discussion that or continue what we're already having as an amazing discussion. This is thanks to Mario, who provided a snapshot of some patients that he briefly mentioned already, but we'll go through briefly here and, you know, start the rest of the discussion. Is there are some patients that have overlapping sort of markers, but have very different clinical outcomes. And so, for example, in the first row, some patients with P53, P10, and RB loss, and who have low or no PSA, but their outcomes are remarkably different. So 65-year-old Gleason 8, local surgical, and by the way, for the sake of this chart, to make our discussion somewhat fruitful, I went back into their charts and I picked out when the NGS was done. So at what point was the NGS taken so that we can understand when the mutations were seen. So if you see here, for example, and this applies everywhere, the NGS appears in red immediately after which tissue it came from. So the NGS was done here, then the patient had salvage RT, Lupron, and Cassidex. Another 67-year-old, similar age, Gleason 6, metastatic CRPC, NGS done after progression on ADT and Zytiga, now has gone through carboplatin and Texetir, had to go off due to leg edema, so side effects from Texetir and cabazitaxel, and unfortunately has gone to brain mets. 72-year-old, Gleason 9, metastatic disease, status post-RP, salvage RT, ADT, urethral mets, and NGS was done there. So next row, P53, P10, 71-year-old, Gleason 7, NGS done early on, CRPC, and sort of having quite good, greater than 25 years, I would say not just quite good, but fantastic follow-up with minimal disease. Even an Axman scan showed no metastatic disease 25 years on. So 88-year-old Gleason 8 with a tertiary 5 pattern, metastatic disease, ADT, on enzalutamide, liver biopsy for the NGS. And so then there's the P53 with RB, 58-year-old, NGS done on the RP, salvage RT, ADT, docetaxel, abiraterone. P53, Gleason 10 disease, 75-year-old, NGS was negative when it was done, sorry, that's what this minus means, when it was done for after the RP, and then trying to remember why I put negative here. I think, and Mario can correct me if I'm wrong, I believe the patient had a second biopsy at some point, or this negative is just a dash. So no, actually, I think this negative is just a dash. I apologize. So it's just NGS P53 mutation done early on. The next patient is a 79-year-old Gleason 10, very high PSA, metastatic CRPC with liver mets, multiple lines of treatment, and had an NGS done from liquid biopsy. So we're also entering some patients who have liquid biopsies now done. The other patient in this row, 70-year-old, Gleason 10, metastatic disease, also to liver, multiple treatment lines, NGS from liquid biopsy, and on capacitax and carboplatin. And then the last two are Gleason 9, NGS with a very high PSA from early on. And then the last one is small cell, so that's interesting, obviously. And no NGS is routinely done on small cell, obviously, in our practice or anywhere. And then we basically have a patient who was on the ROVA-T trial and unfortunately progressed through that and the first-line chemotherapy agents and has already passed away. So this sets up the idea that, again, we have, as the discussion has been going, we have patients with similar marker sets, again, for what we have, for whatever depth we've interrogated, who have very different clinical outcomes. And a lot of things are still unknown. So I think that's just the end of the clinical portion, and back to the discussion we go.
Yeah.
And I'll leave this slide up.
I just picked those cases to say, it's not the molecular marker, it's not the Gleason score, it's not the duration, it may not be the duration of androgen deprivation, because you can do bad, you can do well, you can do bad, you can have bad markers and be treated for a long time, and you could have just local disease. And then you have the small cell, which is the only, this is, not many I've seen, this is the only group that is consistently associated with a very poor prognosis, doesn't respond to treatment, has a very short survival. So, there's so much overlap. And the more you read, at least myself, I get very confused about what is it really that we consider a neuroendocrine phenotype. Do we call this a neuroendocrine phenotype, or should we start from zero? Should we start, now that we have so many more markers, much more experience in various areas, and probably a lot more therapy available, wouldn't this be an opportunity for us to sort of draw up a plan and get started in collecting what we think is reliable information? I mean, the West Coast experience to me was very enlightening in that I don't know that we learned a lot from it, because we went saying that a lot of them are neuroendocrine, and now we say that they're probably not neuroendocrine because we don't know what neuroendocrine is. So I was just that's just my thought. And when Eugene was preparing his lecture, he said, "Can you illustrate this with some cases?" I just gave those cases to him, and just that. So that's all my.
Thank you again, Mario.
Gene, could I ask you to go back to that clinical trial slide?
Yeah, of course. Give me a sec. Back to sharing.
So at the beginning, Nate Brennen asked us, and it's nice to come full circle. He said, we have all these compounds in the lab, yes, that can make neuroendocrine cancer disappear. And we want to help you guys to design trials. And this slide I liked because it is going away from a morphological characterization, which pathologists will never agree on. And we know that because in 30 years, they have not agreed, except for the pure small cell, to a biomarker-defined way of naming this or calling this. And I like these trials. Take DLL3, for example. So the agent is not going to go anywhere, ROVA-T, but DLL3 is a marker that is found in about 70 to 80% of pure small cell prostate cancers, but it's also found in 15% of usual type adenocarcinoma. And this is Misha Beltran's work and others. The same is true of number 5, DKK1. DKK1 is a secreted substance that occurs in people that have Wnt pathway activation, but no one would say that a Wnt activated tumor is always a neuroendocrine tumor, but there are therapeutic compounds against it. So I would encourage us as a group to pick our 3 most relevant measurable targets that there is a drug against, or that there is a drug that can induce synthetic lethality in that biomarker context. And then to design trials with those biomarkers being the eligibility criteria. So instead of saying you have to have one of the 7 Aparicio criteria, or that you have to have P53 and RB1 loss, we could say, we're gonna do a trial for DKK1 positive any prostate cancer, which may enrich for the clinical aggressive variant, but it will not be restricted to that.
You know, my only problem with biomarker-driven trials is that if a study is negative, you don't know whether the biomarker is not relevant or whether the drug is not effective. So you unfortunately will need a control. So the most appropriate way of designing biomarker-driven trials is to have one arm, patients are randomized one arm, to see what happens in the biomarker arm versus a control, which you pick a standard treatment. I like your idea, Emmanuel. I think it's the way to go, but I just don't know that designing a clinical trial in that setting without a control is going to be the answer, is going to be enlightening. Although we can, for instance, pick patients who have RB loss plus something, no AR or maybe P53, and then pick those cases and see, first of all, try to figure out how often we see them, and then design a therapeutic plan for these patients. I should say though, the small cells are exquisitely sensitive to radiation therapy. So if I have a man over the years who has a large mass, who has a pure small cell, and has systemic disease, but is likely to be obstructed, I give him radiation first. And the small cell model we used to give, we now use chemotherapy, but I don't think the chemotherapy for the small cell of the prostate is as effective. And most of the time you end up with a patient in renal failure, diverted, or needing a Foley catheter, and becomes a big issue. Although, if you give them radiation, they're exquisitely sensitive to radiation. Maybe that's the clue of one way of going.
Can I ask Nate and Sam about DPP8, because they've worked on that? There's this company, as you can see in the middle, number 3, BioXL, that has this.
I just sent an email to John and Sam asking the exact same question.
Yeah. So go ahead.
Yeah, so it's very interesting. Talabastat's one of these weird drugs that went through several incarnations. It was originally developed as a DPP8 inhibitor. DPPs are dipeptidopeptidases that cleave after prolines, dipeptides, with a proline in the P1 position. It was reincarnated as it was originally developed as a DPP4 inhibitor for diabetes. It was reincarnated as a FAP inhibitor, even though its IC50 is like 100-fold less. Didn't do well, got picked up by this company and was reinvented as a DPP8 and 9 inhibitor. They're all obviously family members. And it hits all 3 of those better than it hits FAP. So I actually don't know much about what the connection is to neuroendocrine prostate cancer. I actually I was very curious about that myself.
And interestingly enough, dipeptidopeptidase 4, just because you mentioned dominant negative, in cancer has been studied mostly for its dominant negative mechanisms, Emmanuel, just FYI, unrelated.
Yeah, we were asked to participate in that and we declined it. And Rahul Agarwal picked it up from UCSF, and he's the PI. And the poster that he presented at ASCO, it was ASCO GU 2021, they are seeing some activity. So maybe that could be revisited. And I wanted to ask you, Nate, are the DPPs measurable in human biopsy materials?
There's good antibodies for at least DPP4 and FAP now. although that's been controversial until very recently. Steve Balk has done some work. I think it's Steve Balk has done a lot of work on DPP-4 and prostate cancer. But DPP-4 is like pretty much ubiquitous. It's everywhere.
While we have the clinicians still here, I'd like to give kind of a slight Patrick Henry speech because I've heard from a variety of people now that the Hopkins experience is different than the rest of the world. I can't, as a person who used to run a journal, I can't find a paper that makes that statement so the world could hear it. We are one of the centers of excellence. And if we are getting a longer term response treating our patients with delayed hormonal therapy, that needs to be brought up because we're living in a world asking the question about trying to do earlier and earlier hormonal therapy. And if what you're saying is that the Hopkins experience, regardless of how we got there, is essentially a fairly uniform delayed hormonal therapy, but those patients are in fact living longer than most of the other clinical trials, that needs to be written up by the Hopkins community stating that. So I'd like to get Sam and the other clinicians to tell me what you're thinking about how you're going to declare that to the world.
Well, I guess first we have to figure out if that's true.
Okay.
Do we treat people differently at Hopkins than other centers? I don't know. I mean, we do tend to delay hormonal therapy. I've only been at Hopkins, so I've never been anywhere else. So I don't know what everybody else does. I don't know if we do it to a degree that's so unbelievably different that, getting back to Nate's little.
So John, so I don't know whether Kathy is still here, Kathy Marshall. Kathy has a paper who was submitted to the Journal of Urology and now is under the second revision. We expect that to be approved. And what we did, John, is we examined the trials with in non-metastatic castration-resistant patients with a 3 androgen receptor targeted treatment, showing improved survival and improved a prolonged metastasis-free survival, darolutamide, enzalutamide, and apalutamide. And in all these trials, all patients were initiated on androgen deprivation when they had a rising PSA following radical prostatectomy. So we looked at our series here together with the CPDR, and we had thousands of cases, and we came up with about 800 patients who developed disease progression, never received androgen deprivation until they developed metastatic disease. So these patients never had non-metastatic castration-resistant disease. We looked at the survival from the time of radical prostatectomy. And the reason we did that is because none of these trials reported what the conditions were when they were initiated on hormonal therapy. So we said, well, okay, let's measure it from radical prostatectomy till the end. One of these trials had data from the time of diagnosis. And our results are exactly the same. In fact, the survivor is like median survivors in the order of about 21 years or so. And when we look into patients who had PSA doubling time, consistent with the doubling time that was required for patient eligibility in these trials, it was exactly the same. We're talking about a survivor somewhere around 16 years or so. So that's the best that we have here in terms of comparative comparisons. And I personally don't think we'll ever have a trial looking into this, but we don't know what the pattern of disease is when they become castration resistant. It looked like the progression was the same. When they developed metastatic disease and were then initiated androgen deprivation, the median survival of those patients in general is longer than 5 years. We're talking about 6 or 7 years, but we catch them early because we have, routinely done bone scans in these patients that are asymptomatic. But it doesn't seem to be much different than the data in these patients. I don't know what the pattern of progression is in patients who were on the non-metastatic castration resistance. They already have an androgen receptor targeted drug. A number of them will have an androgen receptor based resistant, like the AR-V7 expression, for instance. They won't respond to the second. They all will receive the androgen deprivation for a decade or so. So I don't think anyone does. I don't think anyone has data that will place this in context of the timing of androgen deprivation. I can just say that in our data is probably as long as those trials that initiated androgen deprivation at a time of biochemical relapse.
But Sam, I thought you were telling me that when you looked at our Hopkins history of patients that have radicals, curative therapy, those local disease, that survival after that looks like we're just like every other center, very, 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 very good. But that when you looked at the survival of men that come into the clinic for metastatic disease, so don't worry about early treatment, late treatment, just metastatic disease, that if you're come to Hopkins, you live longer than what you would from other clinical trials where they've got control arms and they're saying what the survival is. So is that not true?
I told you about that long ago. Someone a couple years ago sent me, and again, I don't know who did this analysis, but it was intriguing because they looked at our patient survival compared to the SEER database and another database, I can't remember. And what you said is the first stage 1 through 3, we were identical in terms of our survival. They looked at like 200 patients or so from Hopkins. But stage 4, it looked like just coming to Hopkins doubled your survival. So again, I don't have all the details of that. And maybe that's something, I don't know how easy that would be for us to look at in terms of outcomes.
Well, not to be politically insensitive, but every day when I come in and I hear the radio on and I hear about how the Dana-Farber invented hypoxia or therapy or PDL1, this might be worthwhile because our prostate cancer group, which used to be the world's leader, is, I think we are about what, 5, 6, or 7 and going down. It would be nice if we actually thought we treated patients and their outcome was actually better than the average, that might be shared with the world.
Yeah, John, there's 2 caveats there. One is we are well known for not treating patients with hormone therapy until they get a MET. So a lot of the people that we get with metastatic disease are untreated. So they're hormone naive. So that person has a much better prognosis than someone who's non-metastatic CRPC who then becomes metastatic CRPC, right? So that's number one. And number 2 is, of course, we have a lot of clinical trials, and I think that does prolong survival compared to the community. Let's say, so if you compare Maryland versus Hopkins, Hopkins is better than the state of Maryland. I mean,
right.
Because we have all the clinical trials. There's a caveat that I want to point out with respect to the small cell thing and why it will be difficult to publish. And that is that we now have 3 studies that unequivocally show that your overall survival, your length of life will be increased if when you have non-metastatic CRPC, you receive apalutamide or enzalutamide or darolutamide, okay? What those studies don't tell you is when those patients eventually die, having lived longer in the first place, what do they die of and how do they die? And actually, a higher proportion of those patients, I believe, die of these small cell neuroendocrine visceral crises, brain crises. And so, yes, we might be seeing less of it by not giving the hormone therapy early, but by giving the hormone therapy early in a population level, people are living longer. So that's a good thing, supposedly. But as a consequence of living longer and having their AR blocked longer over time, you're increasing the chance of finally getting to neuroendocrine right before they die. But meanwhile, they've lived longer. So it's a circular thing there.
Well, but if what you said, I'm just using Aristotelian logic. and the issue is that you've just set up a situation that's testable, because the idea would be then that those patients we should be enriching for because they're living longer and they're coming to Hopkins. So I'm hearing that, but we don't have such neuroendocrine patients. So I can't figure out how we can have it both ways. The patients you're saying that we treat this way live longer so that they can develop neuroendocrine cancers, which you're telling me kill them. But you're also telling me that we can't identify them to do a clinical trial. Now, how does that work?
Well, I think to look into these numbers, it would be impossible and a lot of speculation. I can just say that we've entered a fairly high number of patients into some of the prospective randomized trials in the US, for instance, in newly diagnosed metastatic hormone-sensitive patients. I think on the charter trial, we had over 60 patients. So we were one of the largest accruing institutions. And then we had others. We didn't, the outcomes of our patients was not any different than those in the other institutions. I mean, a institution was not a parameter that was important for outcome here when they did the analysis. I don't know. I have a feeling that duration of treatment, or actually treatment-induced, a aggressive subtype, may not be a huge factor here. We all treat our patients earlier anyway. Even here at Hopkins, we are succumbing because we do have PSAs, and patients come with PSAs quite often. It's almost very difficult to withhold treatment. I remember about 10 years ago, we would never talk about intermittent hormonal therapy. Now I would say that probably at least half of my patients, I have to give intermittent hormonal therapy.
Well, but let's come back though, because you're right. You bring up a really important point. But if I'm a first-year medical student or graduate student and I read the literature, I'm about to figure out what I'm going to do with my career, and I'm hearing that the patients are all dying of neuroendocrine treatment induced. That's how we started this discussion, okay? So either we are not to be listened to, or we are in wisdom factor. So one of this thing about this meeting was the idea that we have got wisdom factor here, but we need to articulate it and say, wait a minute, do we believe what is in the literature? Either we do or we don't, or we say we're going to just, we've got Jonathan Epstein, the world's experts on this, Dr. Tamara, we got all the pathology down, and we've got the history of an outstanding center. So are we just turning the other way because we don't think we have a legitimate opinion? Or do we say, you know what? We don't see what is the last 3 or 4 science papers, because this is what's driving research. So if you believe what we're doing, it is affecting the kind of clinical trials that you're going to be able to get funded and the type of clinical or the basic science research we can do, because people are believing that lineage plasticity and treatments that we're doing, we're driving the patients to that phenotype. And they may be right. I've been wrong on a lot of things in my career. I'll be happy to admit it. But somewhere along here, we need to put not a line in the sand, but what we think. And it's not what John Isaacs thinks, because I'm not a clinician, but what do our clinical expertise think? And so what I've heard today is we've got some really outstanding expertise, but I'd love as a reader to read it.
John, can I give you an analogy from lung cancer?
Sure.
So as you know, there are these EGFR positive non-small cell lung cancers. And before we had EGFR inhibitors, those patients had a survival of 12 months. After the advent of EGFR inhibitors, their survival went to 3 years, but 10% of those patients, upon exposure to the EGFR inhibitor, they converted from a non-small cell lung cancer to a small cell lung cancer by losing RB1, okay? So is that a good thing or a bad thing? I would argue it's a good thing because that patient is now living 3 years instead of 1. But the bad thing is that 1/10 of those patients are going to die of small cell now. So this is the dilemma that we are faced. Do you treat early and take the risk that you're going to get a small cell in some to benefit the greater? Or do you not treat early and go against the rest of what the country does with the hope that you're not going to induce neuroendocrine, but your patient might live less long?
Well, I'll stay out of it, but as I said, I wanted to hear what the Hopkins experience concluded. And there's not one person, but how does, as a corporate group, for the last 35 or 40 years, we've been one of the leaders in this field, and we were the leader for a while. And I'm just saying that I can't pull a paper where I can say, oh, here's our dream team's approach.
Well, I think our approach is still in the works. This is still a lot of work to do. Treatment is always going to be tough. If we go from, the molecular evolution, the one common phenotype of this type of tumor is the erosion of cellular identity. They are highly heterogeneous. No matter how you treat them, they always find a way to, to come back. And so we discussed a little bit about how to prevent this from occurring. And so there are some interesting ideas in our manual, etc. We're talking about how to target P53, for example. It arises before RB1, right? So if there's a way to target P53, and because it arises early, you actually have the potential to prevent it. And the one approach is the bipolar androgen therapy that we have been talking about. And the other one is actually, there is a bunch of papers just published actually a few days ago. So it's Bud Vogelstein group. So it's about this concept of mana. So any mutation actually has the potential to be presented as a new antigen, including P53. And I haven't read the paper, but I heard a lot of buzz in the social media. You might want to check that out. So P53 mutation can actually be presented as a target for immunotherapy. So this is something you might want to look into. And at least from those high profile papers, it looked quite interesting actually.
It was very interesting, and it's back to back in various publications. There's a Science paper with a P53 specific antibody for, a neoantigen version of it, et cetera, et cetera. So yes, it's very interesting, June.
Well, let me share something with you. Before we had antibodies to the androgen receptor and before we had it sequenced, so the idea was, well, how are you going to find the androgen receptor? So it turned out that a guy named Shizan Liao thought about it for a minute and said, I'll bet you that humans make antibodies to the androgen receptor, particularly men that have BPH. And so what he did is he ended up bleeding men or getting blood samples from men with BPH and showing that they had a protein that recognized the androgen receptor. So you want to talk about a neoantigen, it's kind of how you look at it, right? Do you believe that patients that are dying have never made an antibody to P53 if it's mutated? I don't know that. But what I'm asking is, this was the argument that Don Coffey brought up about genetic instability. It was going to produce all kind of neoantigens. So I don't think that, so that's a very important idea, but it doesn't get back to the situation we're trying to address here, which is, could we do a clinical trial with neuroendocrine cancer? Because I think that's the take-home message from today, is to start the dialogue. If the answer is no, okay. But is it no?
Well, I think we can't do a trial if we call it neuroendocrine cancer. But if we say we can do a trial of patients who have this profile, whether it's a mutational profile or something, because neuroendocrine cancer is such a nebulous thing.
Okay.
If we said we could do a clinical trial of people with P53 RB mutations or P53 P10 mutations, or some kind of classification that was much more specific than this kind of broad, nebulous, uncertain term. I think that's what we got to be. That's what's, to me, I just think we should stop using the term and really define it based on, some kind of molecular definition more than some kind of, to me, non-specific, just, Tamara showed the variation. That's kind of a spectrum. So where are we? So I don't think I think we have to just stop calling it that.
Well, is Vasan still on the line? Vasan, are you there? Okay, because I thought we heard from Vasan a very interesting situation about circulating tumor DNA and methylation on it that would potentially allow you, as a useful screen because you're essentially then, looking at all the body positions, where the Mets are. And that might be an interesting, if that was practical. I wanted to hear from him, is that 5 years away from now? Is that 6 months away from now? What's the time course for such an analysis? Because that would be
but it seems like based on what Tamara was showing, it seems to me at least unlikely that that's just going to be another molecular marker that's probably not going to be, wonderfully specific. It's probably going to be the same thing. It's going to fall on this. It's like a spectrum. This thing is like it's diffuse. It doesn't seem like there's one or two good markers that's going to define everything. I don't know what he was exactly referring to, but I mean, you really want to see a nice study showing that there's some real strong DNA methylation association with whatever. But what's the definition? If we don't even have a definition of NEPC, then maybe it's a methylation profile we should be going at.
Well, but if you said, like Sam was just talking about for markers, if you defined the marker being that you had to have a certain methylation pattern,
yeah,
and you said that's the pool,
right, and don't call it NEPC.
No, just correct.
Whatever.
But you enrich for what you think would be that phenotype. I mean, you could look at it to see.
Yeah.
I mean, the question is, if every patient is on the full spectrum, or are there modal parts of that spectrum? In other words, where there's a cohort of patients that do seem to cluster in a certain, and so you're not looking for something that includes 98% of all patients, coming in the door, but it's something, on the order of 20%, 15% that you could subdivide and then focus on that group, that limited group, where you could both monitor, essentially the blood level and then some particular therapies, and then see, kind of build on. So we got to have a, starting point.
Nate, could I ask Nate real quick? Of those compounds that you mentioned loosely in the beginning that you're seeing these tumors melting away, are there any genomic, epigenomic, or transcriptomic features that you've identified that you think might be either linked to the response or driving the response?
We're very early actually in those analyses. I can tell you one's an epigenetic regulator that is overexpressed in prostate cancer, but I'm not sure what that really means biologically. The other one targets cell cycle progression. So, I mean, it makes sense to some degree with the RB1 loss, but molecularly, do we have like, this would define the population? No. Do I think it's possible to do that in the relatively near future? Now that we have the models, yes, it's feasible anyway. I mean, another question I had is, right, if we're, Emmanuel, you seem to be in the camp to think that we are driving patients into this treatment emergent small cell. They're living longer, but they eventually succumb to that disease. We have a radical prostatectomy program, or not a radical, a rapid autopsy program. Can we enroll those patients and start, because as far as I'm aware, none of the patients we've done so far have that phenotype. Are we just, the wrong patients are in that, cohort too, and we need to be looking for different patients?
I'm glad you mentioned that, and we are under enrolling in that rapid autopsy program. I think as a group, we could have done better. The last person that I referred to that program, I think, was 3 years ago. So I myself have not done a good job even of thinking about that. So perhaps we should have another meeting with a smaller group and try to bring that back. And maybe focusing on these that we clinically call neuroendocrine.
I just saw, Bill can probably tell better than I can, but I think that, the Pelican study report that Steve Bova reported, he actually saw about 12% of the patients had what he called a neuroendocrine phenotype. And then I wasn't so clear on the autopsy. These are 33 men who had a warm autopsy, and he just reported a bunch of data. And there was a proportion of these patients who had a neuroendocrine evidence on the pathology. I was a little confused how actually came up with that.
I think that, I think he had 2 patients which expressed multiple neuroendocrine markers. And I think that was pretty much, pretty much the characterization that led him to declare that those are neuroendocrine. He did have some very interesting data about, patients that had pain and patients that didn't have pain. And the patients that did have pain were much more likely to have even a slight production of neuroendocrine markers. But anyway, so I think I was thinking about the same thing, Mario. I think, that population does have some cases which are certainly make neuroendocrine markers, but I don't think there's any clear, small cell or outright neuroendocrine tumors in that group.
But Billy, that group, because it was done so long ago, is an incredibly good reference point.
No, I understand.
Now you've got a group of patients treated very differently, right? And if you did the autopsy series on 33 consecutive patients and you came up with 23% or 25% neuroendocrine, you'd be able to say, oh, it has actually been induced. Because Steve had all those patients and the worst thing they got was maybe Casodex added on to LHRH analog.
Yeah.
They didn't get any enzalutamide. I mean, they didn't get enzalutamide.
Sure. They didn't get Abby or enzalutamide.
They actually have flutamide.
Yeah, they got flutamide.
That was like the 90s, right?
Yeah.
I think
Yeah,
it
there
was
was
last
actually,
century.
some of them were actually treated in the 80s.
The 80s,
Right.
yeah.
Correct. So that's why I think but that's a really unique, let me back up for a minute. I do think that that's a really unique Hopkins resource because that is really solid data. The issue is that, to compare it to a new autopsy series, I mean, is Ken on the line still? I mean, Ken did a phenomenal, autopsy series at the University of Michigan.
Yeah.
And at the time, the average Ki-67 in those patients that all died was like 15%. And he only got 28% was the mean expression of androgen receptor. So, is that the same kind of patients that we have now? I mean, it seems like we've got two really nice autopsy series as controls from what used to be. And what we need is one really good prospective study, or at least forward study from here, where looking at the new patients. So really, Emmanuel, that you were in the past really good about this, helping us to get patients in the autopsy series. We really need to really revitalize that.
Yeah, because you guys are actually making some progress now, getting some xenografts, right?
Yeah.
I mean, that's a big deal because they are not easy to make, or actually, and you got them in culture too, right?
Yes, we've made cell lines from them.
Yeah, which is like impossible to make a new prostate cancer cell line. So, I mean, that's a very interesting point that you raise. I mean, do you think that's a general phenomenon that's different between, I mean, when I scan through all these data sets and you get, you go to the breast cancer, they got 150 lines, colon cancer got 150 lines. I mean, we're still working with the same 6 prostate cancer lines. That's got to be with something.
That the group in Australia at the Monash, they think they've got about 100 new xenografts. And of course, Nora Norvone at MD Anderson has got, some about 100, and Eva Corey. So, but what really changed things was the triple deficient mouse, and the realization also that when you take a castrate a sample from a patient that's been really aggressively androgen ablated, you don't want to put it in an androgenized host. That's you put it in an androgen ablated, and now the take rate's more like on the order of it's still not 100%, but it is like more like 30 to 40%. But also those cancers are having Ki-67s of 80 to 90%.
Right, and there hasn't been any increase in microsatellite instability. I mean, in patients who fail now, has there? I mean, it's still the very so as we know, even the small number of prostate cancer cell lines that we have, most of them have microsatellite instability, which is very unrepresentative of what patients are dying with. And unless has there been a change in any of that, Emmanuel or Mario or Sam or any of you guys know? I certainly haven't seen that. Is it still the same, 5% or so? Or is it less or more?
I think we've got Friday afternoon attrition here.
Yeah, well, we lost Emmanuel, we lost Tamara. So
I was going to say, at one point, people were looking around for good ideas for a PO1, and I've never understood why we didn't build one around the rapid autopsy program with the different expertise that we have here with sequencing, PDXs, et cetera, et cetera, et cetera, that wasn't an obvious choice, but.
Well, I think that we've been talking about this for a long time in a sense that what happens with the advanced patient population, and today it's so different than what it used to be. First of all, they have a different disease pattern clinically. They receive a lot prior therapy than they do, different therapies, more targeted treatment. We target their androgen receptor repeatedly until we can't do it anymore, a lot more than we used to do in the past. We do have a number of protocols. So I would propose that we'll maybe put it down in writing in terms of a protocol. What should we do in every man who has advanced prostate cancer at Johns Hopkins? And that will take a huge, a really huge effort, I think, but that's the only way. I personally think that I'm with Sam, calling them neuroendocrine after so many years. And today we still don't know a lot more about that than we used to in the past. I think that maybe it's a sign that we need to go back into the drawing board and redefine that. And, we're getting into precision medicine now. We are designing our therapies based on molecular markers. And, that subset of patients that you come in with aggressive disease and we give them a treatment and we end up with a 30% response rate, that era is over. I mean, it's finished. And I think we can probably understand biology better, but to do this, I think that everyone who comes in, we define them clinically, we obtain tissue, and we define them molecularly. We see a fair number of patients. So let's do that for a few years and come up with a more solid way of hypothesizing. I mean, we do it, everything we're still doing it is we're doing it retrospective. I mean, we're picking up data that was old or data that we're doing in some clinical trials, the patient selection there. I just have a feeling that this advanced subset of patients that we see extensively treated shouldn't be called neuroendocrine.
I completely agree with you. I mean, that was, remember when I gave our group thing, that Baltimore project idea, part of it is this Tempest study IRB that I'm putting together. That is idea of every patient needs to be done sort of in a prospective manner. Everyone who comes to Hopkins we're not the community, should be getting prospectively in our group's defined way, getting circulating tumor DNA, et cetera, the right biopsies in a very standardized manner with standardized imaging to really build up the data to understand how in the molecular driven age we can study them. So 100% agree with you, Mario.
So what about double negative? I mean, is that a better term?
Double negative for what?
AR and neuroendocrine phenotype.
So I have something to say about that. So I think there's an issue with how you define the second negative. AR negative is relatively easy, but if you are saying neuroendocrine marker negative, so what are the markers? So the current definition is based on two, IHC, chromogranin, and somatophysin. But there are many other markers as well, right? And AR has an issue as well. I mean, AR can be quickly degraded if you stay inactive. That does not necessarily mean it's not there. And
yes, but by RNA-seq, you can define it by RNA-seq, and you're not depending on one marker. We've got a 10 gene profile, and again, they're
yeah. So you know, the sampling even for the autopsies, I think is slightly biased with this caveat in mind. So currently Angelo, I think, has about 15 autopsies. Only one of them he can definitively say it's AR negative. And that patient, actually, I remember that patient because my technician actually made a friend with him. And so he actually had adenocarcinoma to start with, ARV7 positive in CTC, but only after 3 months, everything was gone. And
Yeah, but
so
whoa. When you say that, what you got to realize, what Angelo is saying is in that patient, there's usually 5 to 6 or 7 lesions. And so when he says they still have androgen receptor, at least one of them has it. But we've got those patients where 5 other lesions don't have androgen receptor by any methodology you want to do, by essentially very sensitive sequencing.
That's based on the animal. I mean,
no, from the patient.
No.
From the patient. That's not, those primaries were sequenced, or at least for RNA.
What is that Hopkins series or the?
You're actually on the paper.
Which one? Which study are you talking about?
The JCI Insight paper that just got accepted.
We can talk offline about this, but the point is that I think we can agree that there are methodologies to help define those terms. Those are not ambiguous, I don't believe. The concept of being AR, positive or neuroendocrine positive from markers, and we've got other examples, because again, that group is not going to, I mean, if essentially, you've opened up the door, good door, in that if they don't have androgen receptor, you're not going to try to bang on the androgen receptor anymore. So you're talking about an alternative approach, which opens up, and we can talk about how to do that. But the issue comes down, and I still kind of, to end this conversation, I guess not end, but bring it, is the realization this is a catalyst to figure out who should be working with who, and how we should do this either for program project grants or for specific clinical trials, or it's called the coffee hour, and I guess I'm now the oldest person around here, and I just am saddened. I think Don would be saddened, because we've got the A team and we're getting marks of a B and maybe even a C+ in the outside world. We're no longer the A team. And if anybody wants to argue with that, all you got to do is ask, where did the big program projects go? So my brother Billy's looking at me, and he told me right before this meeting, he said, John, make sure you remain quiet. And I was thinking, well, I can remain quiet, but I got to look at myself in the mirror. I'm thinking about to whom much is given, much is expected. And so we've got a lot of really good people, and people not all on the line now, but we can't any longer just say, well, I'll go back to my lab and go working, because we really do depend on each other.
Yeah, I think the A team, I mean, the dream team concept, I think, is fading. I think that they had the ability to accumulate a lot of tumor samples and sequence them, and that's gone. So I think that's, and that was very helpful to do, but I think we're certainly doing as creative stuff as anybody's doing, and I don't think that's I think that should be a rationale to try to do things better and do a lot of things, but I don't agree with that. And I think well, it's a historical thing. I mean, Don Coffey did not want to give samples away. I can tell you that was one of the main things. He said, do not give your samples to anybody. And so we didn't get it in the dream team.
Okay.
Well, I think we also have to remember that, we are studying the 96% of patients or whatever that don't have neuroendocrine cancer. Where do we marshal our resources? Is this really where we want to go when, the vast majority of patients, I mean, as we alluded to earlier, we just did a study. We have 45 paired biopsies. These are men who've had every kind of treatment, multiple hormonal therapies, chemo. We didn't have a single one with neuroendocrine. These were all adenocarcinomas. They looked really nasty. They had huge levels of AR. Not a single one of them had a low AR level. They all had a lot of PSA. So that's a sample of 45, but that means at least, I don't know, 90% or more of the patients we see are like that.
Is there some way?
That's what we should be focused on, because, I don't know. I don't know if we're trying to put a round peg in a square hole, or, it seems like, I think it's important. It's important to, be able to understand this, but,
I think the question is are we driving patients into that state or not? So is this, planning for the future, like not, we're not working on the patients of the past. Is that what's coming down the pike and we need to get ahead of it or not?
It's been 2.5 hours, and I'm now fundamentally completely confused about the basic question that Nate raised in the beginning that you just mentioned.
Good. That means you've been paying attention, Alan.
Well, but we've been hearing that there's apparently was or is some evidence that Hopkins on bulk historically patients do well or do better. But then Emmanuel was mentioning, yes, but if we give androgen suppression earlier, the patients live longer, but the trade-off is some subset of them will develop neuroendocrine prostate cancer. So if we haven't been giving people early androgen deprivation and we've had better or good experience, then those two things seem to be contradictory. If we are giving them early androgen deprivation like everybody else is now, which sounded like what Emmanuel was saying, then it becomes this quandary again. Why aren't we seeing the neuroendocrine prostate cancer? Or are we back to Tamara's?
No, so
it's so hard to define that we're all, it's the elephant. Somebody's touching the trunk, and somebody's touching the leg.
Again, so clinically,
I'm confused as to what the status is.
So clinically,
it sounds like we're not seeing it from what you're repeatedly saying. That sounds like everybody's kind of in agreement with that. Is that yes or no?
Well, historically, patients were, had their prostatectomy, and then when their PSA was 0.2, everybody got hormone therapy. Everybody panicked, and everybody got hormone therapy. And it's sort of become clear to us that maybe that's not so good, because it doesn't cure the patient. They feel like crap. They're tired. It makes them feel old. So our practice has been, okay, lacking any kind of early versus late hormonal therapy study, which will never be done in our lives. We've been talking about it for 40 years. We have decided not to give hormonal therapy for patients with biochemical recurrence. Some of those patients can have biochemical recurrence for a decade before we even see the disease. So we're treating a blood marker. But that being said, the world still gives people hormonal therapy for biochemical recurrence.
Okay, so you say that's a definite differentiation between Hopkins and the rest of the world.
Well, I don't know if the rest of the world is like Hopkins and academic centers versus the rest of the world, or we're really, really, really special. But that
is that true for you, or is that true for you and Mario and Emmanuel?
I think that's probably true for our whole group.
Really? Okay. So that sounds like a solid.
So what the world did is, because all these drug companies making apalutamide and darolutamide and blah blah lutamide, they're all fighting each other for share of the market.
Sure.
Keep leapfrogging each other. So at some point they're going to be given darolutamide to kids in high school, I think, to treat nascent prostate cancer. But what they did is they leapfrogged into this non-metastatic group. And so they did studies in patients who are castrate resistant, who've never had any visible disease, just castrate resistant based on PSA going up. They gave them anti-androgens and have a survival benefit. So it's almost pushing us, it almost says, okay, if once you fail castration, we have a treatment that prolongs survival, maybe we should give castration earlier. So there is a move to move it earlier again, which we are not falling victim to. I tell my patients, this is the data, but we're not going to do it. I don't want to do it. So we are not, I don't think, you may have misheard him. We are not shifting. We're still delaying hormonal therapy until there's and even then it's not clear that's the time to do it.
Yeah, okay.
I don't give hormone therapy till I see a MET on a scan, but that may not even be right. It may be that I should wait till there's symptoms. Because remember, that's when Huggins gave the hormone therapy.
Right.
We've moved it way back, but he gave it when the people were about to die. So there was a survival benefit there because the patient.
Sam, let me come back.
I'm saying, let me finish.
Yeah.
I'm sure some of the men lived, a week longer than they were supposed to because of hormone therapy. He didn't do a formal survival analysis.
But Pat Walsh did.
Yeah.
Pat Walsh did. And he collaborated with Bloomberg on it to do it right statistically. And Pat's famous paper, which no one quotes anymore, and I don't like it, but I have to live with it. The conclusion is that did not increase anybody's survival. And then, of course, the realization is, well, there's anecdotal statements that some people live longer, and that's true. But it's a statistical study. Late hormonal therapy did not increase survival.
I think things are going to change now, just to make it a bit more confusing here. Now we're doing the PSMA scanning. We're finding that the conventional imaging is negative, but we're going to find a lot of metastatic disease at PSAs of 0.5 or higher. So that's going to bring the pendulum back again for initiation of androgen deprivation treatment. So we're going to treat these men. They're going to live for 15 plus years well, they're going to castrate them. And it's going to bring us back to the way, we were thinking in the past. So it's very confusing. But, I do feel that going back to neuroendocrine, I just think that we need to change this, because for all these years we called it neuroendocrine, and we still don't know what neuroendocrine means. And it's probably not very common. So what everybody's saying. So what I was proposing is just these men are getting treated for a long time. We're following them for a long time. So they're living longer, maybe because we're following them longer. In our cultures, if we get a patient-doctor relationship, there's going to be some form of treatment there. And so we don't know whether what we're seeing is because we, let's say, pressure the androgen receptor, or maybe because we're just seeing them longer in the several, docetaxel prolonged survival, radium-223 prolonged survival, enzalutamide prolonged survival, PARP inhibitors prolonged survival. And if you give these things early on, you're going to prolong survival. So we're going to see these men getting some form of treatment for a long time. And when they progress, what I see happening here is that they're not neuroendocrine. They just have a aggressive subset of disease. And maybe we just need to make a different effort on how to define these.
I mean, what are the most universal characteristics of men dying from prostate cancer now? I mean, are they AR negative? More of them are AR negative. There's less AR signaling, I would think.
I mean, all my patients die with high PSAs and bone metastases.
Yeah.
It's all vanilla.
Do they all have V7?
No. Not that we can detect with, there's a proportion that do, but not, maybe they have a low level that we're not seeing, but.
How many of them have high AR amplification?
Well, based on what we just did in this biopsy study with the 45 patients we talked about, all 45 of them had like so much AR, it was hard to even like see the cancer. It was so dark. So it's like, it seemed to be screamingly high. I mean, again, that's a small slice, but we didn't see anybody with low.
But as they pointed out, you're selecting for those patients based on the trial criteria. So, I mean. Yeah,
but the trial criteria was progressing on abiraterone, which is, it's not like that's a special group. That's like 99% of our patients.
That's everybody.
Wasn't it also high PSA?
No.
You know what I'm thinking? I'm thinking over the past 5 years, Sam, we've gotten a lot of biopsies for studies.
Yeah.
And these are usually studies in the castration resistant. Why don't we just try to go back and and look into these. I know it's sort of a little biased because we are putting these patients on the clinical trials, but wouldn't it be worthwhile to look into what happens with patients who are entered on clinical trials, we have biopsy available prior to or during the trial and during the trial, and see whether we come up with some molecular typing and some genomic alteration, some, morphological characteristics that allow us to sort of come up with certain hypotheses in the Hopkins, confine.
Yeah, I think that, if we could get that organized, I think.
Who has that? Who has that tissue?
Well, it's going to be a hodgepodge of different trials where we did biopsies on the trial. A lot of the trials.
When you say, so to educate us basic scientists, when you say you did a clinical trial and a biopsy was obtained, that sounds really inviting. But oftentimes find that you say, well, Fred's got it and he moved to Cleveland and he took it with a cousin. Where are those biopsies?
Oh, here.
When you say here, are you talking about pathology in Angelo's freezer? Are you talking about?
Those are the questions we got to ask them. I don't know. We've done a lot of studies where we've done biopsies and they've been analyzed by our pathologist. Where they go after that, I don't know. I don't know if they're in Angelo's free. I don't know. They're,
some of these biopsies.
Mario, if you have a list of the trials and put it all together, we can send it.
I think that's a start, and we can get back into all clinical trials. John, some of these biopsies went to some research lab, but we also have, pathology in that, and that we can obtain tissue, for instance, with sequencing. That would be an interesting, and come up with a hypothesis, and we study, 100 or 200 patients who were in a clinical trial, was studied prospectively. The clinical annotations are well characterized, they're protocol driven. We have.
Let's stop for a second. Is Billy still on the line? Billy, are you still there or did you leave?
No, I'm here.
Would you share with Mario the issue of when you try to go back and have a piece of tissue that's 7 or 8 years ago under consent, and you're going to take it and you're going to sequence it?
Oh yeah, well that's difficult. Angelo would be the one to talk about that, but yeah.
Just say you want to try.
Yeah,
I do it all the time now. I obtain tissue for clinical practice.
No, but forward you are, because you're consenting.
No. I have patients who I get biopsies that were done 20 years ago, 15 years ago, because we're dealing sequencing now is FDA approved. And
but you're reconsenting the patient, aren't you? Right? Because you're
no, you don't need to.
In the almost all the consents right now, they include the language for utilization of the previous tissue samples. So we didn't have a problem with our V7 population. We have about 600 patients right now. And if we want to get biopsy, get them sequenced, submit the data, it's not an issue.
No, but there is, I think what John's pointing out is that particularly if you're going to go further back before most consent forms in 1990 did not talk about sequencing or that type of thing. And so I think, so you do have to have, a discussion with the IRB about what the consent is. I think it's doable, but you have to jump through some hoops and, because that's what's happened to us, and we have had problems. And June, you know what the problems are. That if we're not getting any money from NIH, then it's not a problem.
Yeah, but remember we solved it. we actually found that the consent.
Let me just comment on this. Yes, if we do a clinical trial, we're going to obtain tissue for sequencing or whatever we want to do, we need to obtain a consent if that was part of the clinical trial. Now, sequencing now is FDA approved. So what I often do in clinical practice, and I do it now, Billy, at least once a week, in one of the patients every week, I say, hey, I think that sequencing may help me to
Sure.
treat your cancer.
Right,
And
for patient care.
foundation and obtain it.
Right.
So what I'm proposing is that we have all these clinical trials, we see what we have, and if we need tissue in some of these patients, they're often here, so we can sequence that, and it will be paid by the insurance. Of course, there is some issues related to the IRB that we can find out, but I would anticipate that probably at this point in time, it wouldn't be too complicated. I mean, the NCCN has guidelines for sequencing prostate cancer. I think we can probably
Right.
do that.
Certainly anything related to patient care, you don't have a problem.
Yeah.
And it's a question about research. And so, and because the problem is, so for example, you do not have to deposit the data that you generate, Mario, into dbGaP, right?
Yeah.
Yeah, you don't have to do that. Whereas if you're doing research, if NIH gives you research dollars and you generate sequence, you have to deposit that into dbGaP, and that's
Right.
what Hopkins has a hard time with. And but they'll let you do aggregate data. I mean, and if you work with them, and there are ways, I think it can be done. But certainly anything for patient care, anything that's like associated with a clinical trial, I think has a much better opportunity to do this, because you argue that it's part of the trial, as part of their patient care.
I've got a technical feasibility question. If you're talking about patient met biopsies, some of the ones I've seen anyway are just scant. Can you even extract enough material from an FFPE block to get good sequencing data from? I think you would want the most you could get, which would be the whole genome versus just a targeted panel. Is that something you do? When you say you sequence patients, I could see you could go back to a prostatectomy or a lymph node or something, but can you actually, from a metastatic biopsy, can you actually get good sequence information?
Yeah.
The problem is that we don't get a lot of biopsies in metastatic sites unless it's in a clinical trial. So most of the biopsies that are obtained, most of the tissues that are sent for sequencing at the time of the initial diagnosis.
Right. So
or if something new happened that required tissue diagnosis, sometimes we can get a hand of this. Now, Foundation will look at the tissue, look at the quality of the tissue, and tell us whether they can come up with enough tissue for making a good, making DNA there, and they let us know. But we have these guys who had a prostatectomy 23 years ago. I have a few of those guys, and I say, hey, are you doing well? I'm not sure why. Is it okay if I get your tissue? And I get their tissue, and I set up the Foundation. And I try to learn something, and we do learn something.
Right.
A lot of
That's our RP tissue, right? That's
so Vossen. I think Vossen did.
The other issue is you might take so much of the sample, even if you can do it with the biopsy, you got to be careful, because maybe it doesn't matter, but you probably leave almost nothing for anything else in terms of things like IHC or any of that.
It certainly wouldn't address the patients towards the end stage. Then we're calling neuroendocrine here, because I don't know how many biopsies we have there, but we do have some biopsies in trials that require these biopsies to be done. I don't know off the top of my head how many patients are in that category, but probably it's not insignificant. Wouldn't you say that, Sam? You probably at least, I don't know, a couple hundred patients.
Yeah, I think so. I think, and a lot of the trials have two biopsies. They have a baseline and then some treatment. And we look, so, we would have we could look at all the baseline biopsies on all the patients, because the treatments would be different. But I think certainly in the last few years, we've done quite a few of those, I think, because we're doing more and more of these, like you said, biomarker-driven selection and stuff like that.
But I guess even what are the barriers to really reinvigorating in a systematic way the rapid autopsy program, where you don't have to worry about biopsy of a single lesion or limited material? You get as much as you want from who cares about PDXs, but just molecular and pathological analysis of different mets. I mean, what's preventing us from doing that again?
I think the barrier is more just
it's work.
It's a hard thing to do.
Yeah, it's a hard thing.
I don't think there's any barrier. I think if we have it set up, it's just a matter of having the conversation. It's a hard conversation to have.
Right. I remember we used to go to when we first started going to Capture meetings, all the patient advocates would be there, and I know they would ask the scientists, what can we do for you? And I would, for year after year, I'd get up and say, well, you could donate if you die from prostate
Your
cancer.
body.
Yeah, you could donate your, and they, that was not a very well received, it's just hard to do it. And you've got to almost, I don't have to
It
tell.
required Marianne. What happened was that you needed a nurse whose job it was, like Marianne, who did it at the multidisciplinary clinic, and she did it really beautifully.
Yeah, oh yeah.
Right, and so we haven't had a person like that to be the catalyst.
Right, you got to get somebody who's going to have
And Steve Bova had Penny.
Yeah.
Oh yeah.
But
she was wonderful. That's a key person.
But is that we just need a person that's their job.
Yeah.
Yeah.
Yeah, and they can do other things too, but that's a key part of it.
Yeah, and I think we just I personally have never got anybody on it, so I'm probably it's just I've never really figured out the best way to have that conversation, and I just have to.
Well, I think you don't have to. I understand a lot of physicians have a problem that they're in the business of trying to keep people alive, but you can introduce the patient to a nurse who's they understand her job is to inform them about the clinical trial, and it takes out that personality thing, because that nurse isn't going to be the person deciding whether you're going to get therapy or not. So I'm not suggesting.
Yeah, I mean that's complicated because that nurse costs that money and that support, and how do you sustain that person, and do you?
Well, that's what I was saying. You were looking for program projects for a while. I think the whole program was, and I've never understood why this wasn't like the low-hanging fruit of like something we should at least attempt to put together.
Well,
not being a clinical person.
All program projects, like all great revolutions, need a leader. So we just need somebody to be the leader.
Che Guevara when you need him.
Yeah, exactly.
I would argue that the basic scientist is not the leader of that program project.
I would disagree.
Well, Billy can talk because he did it for what, a decade, Billy?
It was the most painful thing ever.
Well, that certainly is encouraging to get somebody to step up.
Yeah.
Yeah,
Somebody not on this call.
I mean, I don't know how many times we got up in the middle of the night, and so I think you guys know Leslie Mangold, who works here with Alan. And I remember one day she came in. I mean, we weren't doing an autopsy. She came back from and I said, how'd it go? And she said, we took everything but the fucking fingernails from that guy. I mean, Steve Bova's autopsy was a different type of autopsy. He took a piece of every single piece of tissue, and cut, my job would be to cut the, bones into, dime-sized wafers and do like 100 of those. And so anyway, it was sort of overkill for sure. But and as opposed to, there's one thing about doing an autopsy or tissue harvesting, where you're just going to go in and you're going to harvest the main part of the tumor. And I don't know what Angelo and the group is doing now, but they have somebody, right? There's a person whose job it is to run the autopsy thing here.
Jody Hooper.
Yeah. But the patients still have to be directed toward.
The only thing I will say about the autopsy is it's a stage of the disease, right? It's the end. So, I mean, is that the stage I want to know the most about, or do I want to know I personally want to know about the moment the guy fails hormone therapy. What does the tumor look like then? Versus
that's a good point.
What does it look like after he's had 16 treatments and he's been in hospice for a year? Is it a different animal at that point? And is that what we I see the value to it.
It depends. Can you cure? Can you give that patient something that's going to prolong his life? I mean, have they passed through the narrow gate where there's a vulnerability? That it's.
Oh, you mean the autopsy patient?
Yeah. Well, if you with that patient, right, before he died, was there in the autopsy? Can you identify sort of a vulnerability that if that's the general trajectory 2 months earlier before he died, you could have given him X and he wouldn't have died. At least not, then, whatever it is, they now overexpress whatever. They all go through this narrow gate. They all, it's neuroendocrine or whatever you want to call it, but they're all dependent on one pathway because that's the only path left. They've become resistant to everything else.
I'm with Sam. If I can do something to avoid the neuroendocrine.
I agree with you, but you know.
No,
you deal
a
with
while
Scott.
ago, a while ago, it's still sitting on Vassen's desk. We did this extreme responders trial.
Right.
We had these men had a radical prostatectomy, then developed metastatic disease, and were treated the same way, all at Hopkins. Most of them operated by PET, and some of them never died. I still see them, and I have to give them a call. I talked them out of getting hormones. And some of them I was successful, and they died of something else. I mean, I'm talking about 20 years. And then I have a subset of patients we cannot distinguish from that one. We treat them the same way, and 2 years later, they're all gone. So Vassen studied them with Dassel, and it's still sitting. I don't know what's happening, but it was an interesting group, and I was always interested in finding out.
Yeah, Dassel is at least 12 years old.
They developed some very nice data, I think. I mean, I've heard the talk, and it's, very impressive.
Yeah.
Not sure what the status of it is.
So Mario, just a quick question. You can tell from the initial disease presentation, is it like the primary tumor volume, Gleason, stuff like that. And I assume it's a Gleason 9 or 10 type of tumor. It's nearly impossible to eradicate it with hormonal therapy alone.
Well, by far, most guys who die from prostate cancer have a Gleason 7.
Yes.
Just because of the numbers.
Right. Well, I would say, if you just looking at these biopsies we just looked at, I don't even think the Gleason score is relevant at that point. I mean, Gleason 7 is when they presented 20 years ago.
Right.
Every one of the patients that we see have Gleason 11.
Right. Well, I think that's the thing. But have you looked at some of these primary tumors? If your tumor, the more your primary tumor looks like a metastasis, the worse off you are.
Yeah.
I mean, so if you look at pattern 5, and that's what tomorrow's, the frequency of BRCA2 is like 10 times higher than it is.
Yeah. Mismatch repair genes.
Yeah, right. So totally anaplastic primary tumors are a bad thing. But I think
so are metastatic ones.
Across the board for all cancers.
But Bill, you know what's interesting? Yeah, that may be an important thing. We looked into 80 cases that had a Gleason 5, primary 5.
Right.
Most of them are 5+4. And that had a radical prostatectomy. We did not want to have anyone with Mets. We want to see what happens with them before they get Mets.
Right.
And that was that publication that Tamara was the senior author on that. And we had like 80 incredible resource here. And the interesting thing is we do find some that really are terrible, brain metastasis, and it's a terrible disease, very crazy. Doesn't respond to hormone therapy. And that subset, in general, we had like 31 or 32% DNA repair gene alterations. And so on the radical prostatectomy, and we did have, 13 or 12% mismatch repair gene. Remember that data? But you know what's interesting? About a third of them, they lived for a long time. They were very sensitive to hormonal therapy, and some of them are still alive.
Yeah, right. It's certainly, you can have a really poorly differentiated tumor, and it doesn't mean you're going to die from it.
Yeah.
Yeah, if it's taken out before it's metastasized.
I didn't think you believed in that, John.
Oh, I believe in a lot of things. I'm Catholic. And it's Lent. Not only that, it's Lent.
That's right.
Well,
So
I believe in miracles.
So what did we decide to do?
I'm going to start studying breast cancer.
Well, what they're going to get neuroendocrine next.
Right.
You laugh.
I mean, is it worth just writing?
Prostate will confuse them in breast cancer too.
Well, remember the paper that was written by Jonathan Epstein and I think Bal and basically they declared Gleason 6 non-malignant.
Yeah, I
And
remember
that paper, that paper gets cited quite often. And I think it's an important paper. And
Although Eugene, one of his fatal cases today was Gleason 6 primary. I was shocked by that. So that was
it does happen, but
1 in a billion.
well, no, they'll go back and look at that primary and they're going to have patterns.
There's probably some 7 in there they didn't
Oh
see.
yeah.